Thank Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort
Don't read out their whole bio, you just introduce them and they will introduce themselves.
Oh, okay. Good morning, everybody, and welcome to the Health and Wellness Fair of this Jasmine conference, which is, as I said yesterday, our 7th in 14 years. So we're very proud that we're able to fulfill our goal of educating not only ourselves as as palliative care practitioners, but also our healthcare colleagues and, of course, the public, because palliative care involves the community, involves family, and unless everybody understands it, it really doesn't work. So we're very grateful for you taking the time to come this morning. I'm just going to apologize that the Honourable Sabrina Turner is at another event today, or she had to go at last minute, and we'll have some remarks from the ministry a little bit later in the morning. But now I'm going to introduce, well, first of all, I'm going to thank our sponsors, of course, and they have been very generous this year. I'll just read them out who they are, and some of them, of course, are in the room next door. So please go and see their booths and learn about their services. So that's Healthy Futures, the HSA, Health Services Authority, Health City Cayman, the Wellness Centre, Willow Home Care, Aon, and Baptist Health. So thank you very much to all those sponsors for helping us put on this conference. So I love the term complementary. In my day, we used to call it alternative medicine, and that's a few years ago. And alternative always seemed separate to medicine, whereas really they work together. And particularly in palliative care, medicines, equipment, all that sort of thing is very important. But complementary services are very much at the core of what we do, and it really is important. We've got some fantastic practitioners who volunteer their services to us, and we recommend these services to our patients and their families. And there is a wealth of medical data that supports the use of complementary therapies, from acupuncture to massage to Reiki to pet therapy to art therapy to music therapy. I've missed out a bunch, but they are all very valuable services. And the great thing is they have no side effects. They work very well with what we do. There's no real interactions between complementary services. So I don't call them alternative, I call them complementary. So I'm going to now introduce our panelists. This will be nice because yesterday we had lectures, which are, anybody who was here yesterday, I think will agree that they were really informative, stimulating. It was a fantastic afternoon. But today we're going to do a panel, and the panelists are made up of wellness and complementary service providers. I was going to introduce everyone, but they're going to introduce themselves. So I'm just going to list them. Am I doing something wrong? I usually am.
No, she's not. No,
oh, we're going to do the ministry remarks now. So I didn't do anything wrong. Okay, well, who do I introduce then? Is it Miss Janet Flynn? Okay. Can I have Miss Janet Flynn's proper title? Because I'm sure she has one. I'm sure many of you know Janet Flynn, who has been at the, she's the senior policy advisor at the Ministry of Health and Wellness, and she always comes to these lectures and she supports all the healthcare conferences on the island. So she's very experienced in what we're talking about, and we look very forward to hearing her remarks now. Ms. Flynn.
Good morning, everyone. As Dr. Hopley said, my name is Janet Flynn. I'm the Senior Policy Advisor for Health in the Ministry of Health and Wellness. I must apologize for Minister's absence, but I'm here on the spot to deliver her remarks. So I read as written. Good morning, ladies and gentlemen. I'm so grateful to be here, and unfortunately, she isn't here, as your Minister for Health and Wellness to support the wonderful work of Jasmine Palliative and Hospice Care as they host the 2022 Caribbean Palliative Care Conference. For over 20 years, Jasmine has provided the only hospice and palliative care services in the Cayman Islands, and in turn, the Cayman Islands government and the community have supported them by fully funding their work so that no patient of Jasmine ever receives a bill for the services they receive from the organization. This is a tremendous feat, given that Jasmine provides both in-home and inpatient hospice care and palliative care, inpatient respite services, and 3 levels of bereavement support. Not only that, but Jasmine's mission embodies the often repeated concept of Cayman kind. It is open to all persons living within our shores, regardless of age, financial means, immigration status, or diagnosis. Today's conference, which focuses on palliative care specifically, is set to be relevant, thought-provoking, and challenging, as it will be promoting meaningful discussions around the all-encompassing aspects of palliative care, social, economic, spiritual, and medical. It is important to reiterate as many times as needed that palliative care is more than just a medical issue, even though the need for such care is prompted by a medical diagnosis. Palliative care, which can include end-of-life care, is much broader and can last much longer. As a specialized medical care for persons living with serious illnesses, palliative care focuses on managing symptoms, offering emotional, psychological, and spiritual support, assisting with planning for the future, and essentially ensuring the individual's quality of life. The individual's life, I stress the word individual because it is important to remember that while their diagnosis may make them patients in need of Jasmine's services, people living with chronic or incurable disease have other identities. They are dancers, gardeners, musicians, and storytellers. They're foodies, dreamers, jokesters, and gamers. There are mothers and fathers, or best friends, or co-workers, and as hard as it may be to accept, there are also our children and our babies. Palliative care I'm sorry, I apologize. Palliative care, as everything else, is impacted by rising cost of living, increasing levels of illness, and growing demands on health service providers, global pandemics, and other disasters, general stress, and so much more. As we look back, oh my word. This thing is running like the doctor from Senegal yesterday with her PowerPoint. As we look to build capacity and resilience in our community, it is important that we all do our part to give our people the tools that they need, present and future, to care for themselves and their loved ones. This is what Jasmine is hoping to achieve today by bringing together medical professionals and laypersons so that they can fully understand palliative care as a complementary facet to any life-limiting or chronic illness treatment plan. This conference also marks the start of Jasmine's multi-year educational campaign to educate the community on what palliative care is and the important role it has on increasing the quality of life for those who live with chronic or incurable diseases. Jasmine's educational campaign will also focus on the need to support the families and caretakers of these individuals as they too are impacted by their loved ones' chronic or incurable diseases. I am moved by Jasmine's ambitious goal that no one in our community suffer in silence, by their efforts to provide free, emotional, logistical, and physical support to their patients and their families, and by their determination to bring attention to the importance of palliative care for those with life-limiting illnesses. I know that there is much to be gained from today's event, so I ask only one thing of you. Share what you've learned here today with your friends and family to ensure that Jasmine's message reaches all corners of our islands. Thank you, and may God bless you.
Thank you. Thank you, Ms. Flynn, for stepping in and reading those words, which I think were really, really appropriate to today. So we thank the ministry very much for their support. So I'm now very excited to introduce our panelists today. I don't know if it's a present, yeah, the whole come up here. So if I just introduce one and then each one come up as I introduce them. So our first presenter is Rhonda Cornwall. Rhonda is a life coach and grief recovery method specialist at Hope's Dwelling. She's certified from grief to gratitude as grief coach and a grief recovery method specialist, and holds a Master's of Arts in Professional Counseling from Liberty University. She has experience in trauma, grief, and life and career skills, and specializes in helping women overcome grief and loss. She is the founder of Hope's Dwelling, a life, grief, and crisis coaching business located here in the Cayman Islands that she started in 2018 after the loss of her father. She is trained as a crisis response chaplain with a specialization in techniques for delivering bad news, and provides support to those who are going through difficult times in their lives. And I can tell you that Rhonda has been a fantastic provider for Jasmine over the last several years. And we're so lucky to have somebody who's so specialized in this very important area. So welcome, Rhonda. Thank you. And our next presenter is Gavin Kerville. Gavin is known to many of you, I'm sure. He's a licensed acupuncturist and is at Cayman Physiotherapy. He started his acupuncture training in 2007, studying traditional Chinese medicine and 5-element acupuncture, and comes from a family of medical professionals. As such, Gavin expertly balances his Eastern medicine training with the Western medical approach when providing acupuncture and Chinese medicine treatments. His personal experience with chronic pain has given him a deep understanding of how chronic and acute pain can lead to both physical and emotional side effects. Gavin's ultimate goal is to understand and treat the origin of pain, as well as referred pain, through empathic listening and treatment. So welcome, Gavin. Our next presenter is Elizabeth Knight. Elizabeth is an occupational therapist at Cayman Physiotherapy and comes, I think, from Coventry in England. Oh no, Birmingham, sorry. She trained in Coventry. After completing a history degree and working for 6 years in the heritage sector, she decided she wanted to pursue a career where she could help people and make a difference in their quality of life. She studied at Coventry University and graduated in 2018 as an occupational therapist. She then went to work at the NHS Royal Orthopaedic Hospital in Birmingham, working with patients who had undergone joint replacements and other orthopedic surgeries to ensure that they were as safe and independent as possible following their surgery. She works with a wide range of adult populations and conditions, including older adults, treating stroke and neurological disorders, dementia, chronic pain and fatigue, cancer, arthritis, and palliative patients. And Lizzie, when she first arrived, one of the first things she did was offer to volunteer for Jasmine. And so it's been fantastic working with her. And a lot of people misunderstand what the role of an occupational therapist is. And I'm sure she'll agree, they sometimes confuse it with physiotherapy. but it is different, and it is vital. In fact, when I first came here and there was no OT, I couldn't believe it. It was like not having a nurse or a pharmacist, but she has filled that role, that niche and that need in Cayman Islands, and especially for palliative care patients to try and maintain their independence and their sense of self-control. So we're very happy to have Lizzie. Our next presenter is Ashley Hardcastle, and she is a registered massage therapist at Cayman Massage. She's dual certified as a registered massage therapist and a registered practical nurse, focusing on oncology and palliative care. She completed her massage therapy training in Ontario, in Canada, with an advanced diploma from Sir Sanford Fleming College in 2006. With a great passion to help others, she returned to school in 2010 to complete her pre-health science, followed by her practical nursing diploma, graduating with honors. She is currently completing the final year of her Bachelor of Health Science to further pursue her passion for better treatment and to help those living with pain and illness. Welcome, Ashley. So our final presenter is Rachel Nesbitt. Rachel is a respiratory therapist at the Health Services Authority. Rachel began her career as a respiratory therapist in 2006 after graduating from Fanshawe College in Ontario, Canada. Spending the first 10 years at LHSC in London, Ontario, specializing in adult critical care and operating theatre. She joined the Health Services Authority team in 2019 with the only respiratory therapy department on the island at the time. She enjoys the variety of this role, which includes both inpatient and outpatient duties, such as level 1, 2, and 3 diagnostic sleep testing, PAP therapy initiation, COPD, asthma education and pulmonary function tests, home oxygen, critical care, and more. And I can tell you in palliative care, when people need oxygen and have problems breathing, visit with respiratory therapist is vital for the patient and for us, because we really take reassurance, because it's such a specialized field and is really critical to people's comfort. So thank you very much for joining us this morning, Rachel. So I'm going to leave the podium now and leave you all to it.
Yeah. So we're first time we've done a panel discussion here at one of our conferences, so we're learning as we go. But what I would like to challenge all of them to answering a question as to how they see that their services could benefit a patient with chronic illness or life-limiting illnesses. And then while they're answering that, I'd like you guys to think of any questions that you may have from what they've said that we can then continue the discussion. Otherwise, I've got some cheat sheet questions, but I'll go ahead and start with you, Ashley, if you could let us know how your services could help.
Good morning, everyone. It's an honor and a privilege to be here. So basically, massage therapy can have many effects on the body, affecting many organ systems and how our bodies function and operate. When dealing with chronic illness, palliative care, and oncology, our patients are going to present with very complex medical histories. And it's our job as massage therapists to address the body from a full perspective, from mental, physical, and emotional health. We're going to work with patients to help them calm and relax and reduce some of their stress and anxiety and depression that might be associated with the disease. This is both for the patient and the primary caregivers. Quite oftentimes, patients are presented with these sudden changes of their life, and we can ideally, hopefully, help them battle some of that emotional stuff that comes alongside with it. Massage has been proven to actually encourage some positive hormones in the body. It releases neurotransmitters that help by increasing our mood, our focus, and ultimately give an overall sense of well-being, and actually even a sense of connection through release of hormones such as oxytocin. Additionally, the stress can reduce or increase our adrenal release of Cortisol levels, massage has been shown to reduce cortisol levels with the stress as well. On the physical side, most of our patients are bedridden or losing mobility as their disease processes progress. Our job is to look at what might be causing the lack of mobility and what can we do about it to help them. Sometimes that's due to inflammation, post-surgical. Sometimes it is a neuromuscular thing where our nerves are no longer firing. And we can do our best to address some of these more soft tissue and neuromuscular areas of demand. Additionally, if a patient is bedridden and they're not able to move, there's things that you don't think of, like laying in the same spot all day for hours on end. Those areas become very sore, and those patients can't get up and just move themselves. So they're relying sometimes on caregivers to actually come in and reposition them. So just getting some touch in there and getting some hands to just ease some of those muscular areas that aren't actually contracting and just simply being laid on all day long. Looking at the primary caregiver as well, they're now being asked to lift, transfer, and move the patients in their bed. They're not trained to do this on many cases, so they often suffer from a lot of injuries such as wrists, shoulders, and low back injuries. So we can actually aid with not only the mental side of things for the primary caregivers, but also the physical sides of the new demands that they're put under. The list is really quite endless. We can affect the body from the endocrine system to the muscular system and increase mobility, decrease hypertension. Really, the list is endless in the benefits that massage can offer anybody with any health condition, especially those with palliative care. Thank you.
Awesome. Thank you so much.
Good morning, everyone. So my name is Gavin. I'm an acupuncturist at Cayman Physio, one of two. With traditional acupuncture, we treat multitude of things in the palliative care field. We're sort of dealing with a lot of side effects from medications, so particularly neuropathy and nausea caused by chemotherapy, problems with appetite, sleep, stress levels, anxiety, pain, dry mouth, and constipation. So we do this by creating hormonal changes with needles, stimulating points. This can have an effect on circulation, on inflammation, and can help stimulate the body's own healing mechanisms. In terms of helping family associated as well, stress, anxiety, we have methods of treating grief. There's currently a lot of things that everyone in the circle around people that are suffering are struggling with, including their sleep as well. So with acupuncture, with cupping, with some massage techniques such as gua sha, heat lamps, moxibustion, there's many tools we have which can help stimulate this and help everyone out to live.
Thank you. Thank you.
Morning, everybody. So my name's Lizzie. I'm an occupational therapist, again, at Cayman Physio. And like Ginny said, I often have to describe what OT is to my patients, especially my older patients, when I see their look of horror that they think I'm trying to get them a job, which I can do if they want. But in a nutshell, occupational therapy or OT is all about trying to help and support people to be as independent as they possibly can and to continue to do the meaningful activities that are important to them. This is particularly important with my palliative patients. As Miss Flynn said at the beginning, palliative patient, they're not just, their identity isn't just that they're palliative, they're also a mother, a gardener, they have hobbies, they have things that are important to them. And my role really is helping them to maintain those roles and activities and identities for as long as they can, which they may start to find a little bit more challenging. For example, they may find bathing a little bit more difficult, getting in and out of bed a little bit more difficult, tending to their garden. So really it's my role to kind of empower them and support them to be able to do those things that are really important to them. And essentially to maximize their quality of life. So one of the main things that I do really is I can go to people's homes and we can sit down and we can talk about what goals people want to be able to do and what's important to them. Everybody's different. Everybody has things that are important to them. For some people, having a shower every day is critical. For other people, they couldn't care less whether they had a shower every day. So I go in and we problem solve together. We look at what's important to them. What are the barriers that are stopping you from doing this? Why is it challenging? And then we look together about how we can overcome those challenges and make things a little bit easier. So this could be from equipment advice or adaptive technology like built up cutlery if they're having trouble eating or gripping. It can be looking at a certain activity and kind of problem solving. How can we make that easier for you? How can we change it so that you're able to do it now without the help of somebody else? And I also look at the safety of the overall home environment and just give general advice how you can move better in your environment, how to reduce the risk of falling, how to make things safer, not just for the patients, but for their carers and family as well. So really my role is maximizing quality of life and helping people live the fullest life that they can really for the longest. Thank you.
Thank you.
Good morning, everyone. So I'm Rhonda, I'm a grief coach, and many of you might wonder what is a grief coach and what does a grief coach do? Because of course, coaching is relatively a new field in the Cayman Islands. But as a grief coach, really, I specialize in emotional support amongst other things. But we all know that grief often accompanies a lot of illnesses, those who are, going through difficult times. Grief is a normal reaction. It's an emotional reaction that we have when something begins to be a loss to us. And if we think about, a patient with a chronic illness, of course, they're going to be impacted by losses. And grief is one of those things that are going to come along with it. And so as a grief coach, what I do is begin to help them to process that grief, that emotional reaction that they're having, and help them to start to recognize the losses that they're going to, be going through or experiencing, because oftentimes they are reacting to the losses, but not recognizing them as losses. And so, for instance, a loss that could be, something that they're battling with is, their identity. Who am I now that I have this illness? I can't do certain things. How do I grapple with that? What does that look like in my life? And so that's the kind of discussions that as a grief coach, I walk through with my clients. And so when we talk about, a patient that's dealing with a chronic illness, you also have to think about their caregivers and their family members. And as a grief coach, I also work with them as well and support them, because they too are having their own reactions to what is happening. And so we create an environment that allows people and families and caregivers to connect, to really have discussions about what they're experiencing and what they're going through and what it looks like in the future for them as well. Because ultimately, we want to make sure that the person that is dealing with the illness, knows that they're supported and has the ability to really deal with what they're feeling. Because if you don't, it's also going to impact the other care that you're receiving as well. And so my role is to really walk alongside of them in that journey. And really, I work with patients from the beginning, really to throughout, and also with the family as well, because one of my major things that I do as well is, supporting the family members after a loss as well, and helping them, through that as well.
Thank you.
Hello, I'm Rachel. I'm a respiratory therapist. I guess sort of our role is always kind of concentrating on the pulmonary system. And as it relates to palliative care, we sort of want to help with the breathlessness that a lot of people feel in some of the end stage diseases that they might have. As mentioned before, some people at the end of their stage of disease may have issues with mobility. And when we decrease our mobility, it actually has a huge effect on our lungs as well. So secretion clearance is a big one. A lot of times people don't have a strong cough anymore. So they'll need assistance to help sort of bring up any of that secretion to avoid infection in the chest. We do a lot of deep breathing exercises, which not only helps with the lungs, but also can sometimes help with the mind as well. It's amazing what some deep breaths can really do to change a patient's feeling. And a lot of our COPD patients, and really anyone who has lung issues, they get this cycle of breathlessness and anxiety. And so you get breathless. And of course, when you can't breathe, nothing else matters. So that causes anxiety. When you get more anxiety, it causes more breathlessness. So there's this loop that happens. So we really try to break that anxiety breathlessness loop to try and alleviate some anxiety as well as the shortness of breath feeling. We can offer things like non-invasive ventilation. We can do that in hospital and actually at home as well. So some people may need assistance. They don't have the muscles anymore to support their respiratory system. So they might need some support with a CPAP or BiPAP device. Some require a full ventilator at home, as well as maybe a tracheostomy. Certain diseases will help us facilitate that. I think for us as respiratory therapists, the nice advantage we have right now is we can follow patients from the very beginning of their diagnosis. So we tend to know a lot of these patients throughout their whole experience, because we'll help with the diagnosis of some of the illnesses. And then unfortunately, sometimes they need to be admitted to hospitals. So we see them there, and then we can follow them into the home care setting as well. Home oxygen is another big one that we had mentioned before that we can assist with. Palliative care doesn't require the same, I guess, criteria to have the home oxygen. So a lot of times we'll give it for simply comfort measures, because it does help a lot of patients to stay in the home longer versus having to come in hospital just for something simple like home oxygen. And we know most of our patients would rather be in home than in hospital. And we tried the best we can to work with Jasmine to really try and bridge that gap between hospital and home. A lot of patients are unaware that the services are available. So we do like to try and introduce the idea of it early in the diagnosis so that they aren't afraid of chatting with palliative care nurses and things like that, and helping them know that the support is there, and it's great to have them in the community. Doesn't mean that they necessarily only have a few weeks to live, but some of these patients with chronic illnesses like COPD, it can be really scary process knowing that you have a disease that will progress. So having the support in the community, we are thankful for Jasmine because they are supportive for us as well. So we're happy to be here today and answer any questions that you have about the respiratory services.
That was awesome. Thank you guys so much. So I'm going to put you guys in the hot seat. Do you guys have any questions for any of our panelists or all of them? So someone's coming from behind.
Great presentations. Thank you. This question is for Rhonda. Is grief only exclusive to death? And I probably know the answer to it, but I sometimes I can't unravel in my head the difference. And also, how do you distinguish between grieving and mourning? A layman's perspective.
Yes. Yes, absolutely. Great question. Thank you. So one of the things as a grief coach, one of the things that I like to do is to highlight that very question that you have there, because oftentimes when we think about grief, we think of it as being something very concrete. It happens after a loss. It has to be a death. But really, grief is an emotional reaction. It is a reaction to anything that we've lost that's been significant to us. So you can grieve a relationship, you can grieve a loss of a job, anything that, pet loss is very significant as well. Any type of anything that has been significant to you that you no longer have access to, you can have a grief reaction to that. And so it's important that when we talk about grief, that we recognize that loss, any type of loss, can evoke a grief response. And then to answer the question in terms of what mourning is, versus, grief. So your mourning really is your, I guess to put it in a way that we can understand, is your outward reaction and display of the emotional pain that you're feeling. And so oftentimes, when we think about, there's a mourning period, right? We hear about that. There are activities that happen in terms of recognizing the loss. But our grief is that emotional, feelings and stuff that we're going through internally, that's happening. And so we, of course, know that with grief, there are many symptoms and many reactions. So there's physical, emotional, and it impacts the whole of us. Cognitive, grief is a whole body experience. And so I hope that kind of explains it a little bit.
Hey, thank you. Any other questions? Oh, there you go.
Hi, I have a question for Gavin. So I have recommended acupuncture to patients in the past, and I do think it can help, in addition to pharmaceuticals, they can't always manage all types of pain. And I do think acupuncture is a good way to help with some types of pain, but I don't know. Sometimes they just ask me, okay, well, what's going to happen when I go? And so I would really like a better way to explain to them, how the process goes for when somebody asks me about that.
Absolutely. Yeah, great question. Thank you. Yeah. So initial consultation will take a little bit more time. We'll take a full health history, and that includes everything from traumas and everything that's happened through a person's life, because it all has an effect. We look at certain organ imbalances, or imbalances in the nervous system, which are kind of name tagged as organs sometimes. Sometimes it's more of an analogy than the actual physical organ itself. But in terms of that, there are treatments to detox the body, to clear side effects of medications. Sometimes I'll have patients that aren't progressing with normal treatment, although I feel I'm doing everything right that I should be. And I'll come back to a certain treatment to detox, and that will be what sets the way forward for these people. So your first visit would come in, you'd spend over an hour with me talking and going through it. We then might do some other therapies such as cupping and massage and gua sha, which is like a Graston technique style massage tool. And then we'd put some needles in. Generally, some people are quite nervous about needles. They're usually quite shallowly inserted. And I always get people to take a breath in, and when they breathe out, that's when I tap the needle in, just so you know when it's coming and people can brace a little bit for it. But I have a lot of people come and see me that are afraid of needles. The needles I actually use are 0.22 of a millimeter thickness. So they're very, very thin. You hardly even feel them. At most, maybe a tiny little pinch, and then it stops, and that's it. I also use electrical therapy as well. So using an electrode machine clipped onto the needles, which can be good for certain things as well, particularly neuralgia. I had quite a few patients recently with sort of loss of feeling in their feet, pain, sensations of a folded sock, like a Morton's neuroma, and a lot of stuff like that. Problems with digestion, very effective too. Yeah, and so the needles stay in for about 15 to 20 minutes, depending how strong the person is as well. And then we might use a heat lamp and some oxybustion, which is a herb that we burn, which warms the points and in turn sends a different signal to the brain. And then needles come out, and that's it. Yeah. There is I do 2 styles of acupuncture. So the 5-element acupuncture, we can do points which go in, you feel them, they come straight out. And some people are a big fan of that. Thanks for the question.
Thank you. Any more questions? Oh, yeah.
Gavin, I was wondering if there's any contraindications for a patient not to be able to do acupuncture.
With electro acupuncture, if you have a pacemaker, that's a big no-no. No, generally not. There are points to avoid in terms of things, general patients. For me, pregnancy, there's points that I can't use that can induce labor, which we don't always want to do. So those are mainly the ones which we'd avoid, but some points to create too much circulation with the cancer patient. We don't want to move things around too much. We're more trying to eliminate some body fluids and things like that, basically, rather than create too much movement and circulation in some patients. That's it. Yeah.
Thank you.
No worries.
You got a question? Any more questions? Gavin, oh, wait. I'm gonna see if not, Gavin, I had one for you, but we'll wait.
Hi, morning. My question's for Elizabeth. I can conceptualize the role of an occupational therapist for someone with physical limitations, but could you tell me about the role of an occupational therapist in someone with more cognitive impairment? So, you know, memory loss, confusion, what sort of role do you play in that setting?
Yeah, sure. So that's a good question as well, because OTs don't just help people with physical disabilities, also cognitive as well. So just to take an example of, for example, someone who's had a stroke, they may find that they can't recognize colors or shapes or faces. They may find that they can remember like how to feed, but not the sequence. So I look at what is it about that task that cognitively that you're finding difficult. Okay, let's break it down. Let's find different ways of problem solving and trying to get around that. If it's, for example, colors, if you can't quite, is there a color that you particularly can identify? Would writing things down be helpful? Would using pictures be helpful? For memory, for example, so a lot of my dementia patients, for example, sometimes can't recognize words, or some people will put words on their loved one's doors, but it might say dad's room, and they might look at it and think, well, who's dad? I'm not dad. So it's thinking, well, have you tried their name? Have you tried a picture of them? Have you tried it in a deep red color that they can identify with? So it really depends on what the cognitive issue is, but yeah, there's lots of different ways. I hope that, yeah.
Really helpful. Yeah, I never thought of the cognitive issues. Any other questions? I've got one in the meantime. Maybe you guys can all share with us when would be appropriate time for someone to ask for your help, and how would they get help from any one of you in those departments if they were interested, short of course, Jasmine making the referral. Start anywhere and just answer. Yeah.
So for me, it's as soon as possible, or as soon as you start to notice a functional decline, or that things are starting to be a little bit more difficult. It's never too early to start planning, and that's really important, especially if the condition that they have, they may go downhill quite quickly. It's better to have something, for example, if you know that your mobility or your physical functioning may decline, you may need a wheelchair. And I think as we all know, the equipment on island isn't particularly great. So if you need something a little bit more specialist, you won't be able to get it from here. You'll need to get it from overseas, and that will take a long time. So it's important to have those things in place before they happen, so that when they happen, you're not stressing and you're not worrying, you've already got that in place. And even if you love gardening, for example, and you know that, you know, in a few months you might find that difficult, you know, it's good to have a plan in place of, okay, so when that happens, what are we going to do about it? So that when it happens, it's way less stressful and you've already got the tools that you need to be able to continue that, or like a plan of action in place. So yeah, never too early.
And who can refer? Sorry.
If people have insurance, depending on their insurance, their doctors can refer. I get a lot of referrals from Jasmine nurses. They're amazing. People can self-refer as well. So yeah, anyone really. Okay.
So sorry, what was the question again? Just went blank. Okay, so who can refer? So, and when should you refer? So really for patients, caregivers, families, I would, really say that the first instance of having an emotional response to the situation, to the, to the illness, for the patient, definitely as they start to realize the loss, to realize that they're having an emotional reaction to what's happening. It's a great time to start to have discussions and have support with me. Same thing with the family members as they are reacting to what's going on, and as they're having to support their loved one as well. It's a great time to have that discussion, and of course caregivers as well, because oftentimes we don't think about the grief that caregivers could experience as well. And sometimes working with me helps them to deal with their own grief and their own reactions to what's happening with the patient that they're caring for. So really at the beginning and throughout the time, it's never too late to reach out to me and to have support from a grief coach. And then who can refer? Anyone. The grief coaching isn't covered by insurance. So that is the one thing to, to remember. But certainly, there are opportunities for individuals, doctors, service providers to reach out and to engage my services.
Before you go on, Rachel, I will add that we are really blessed that R3 has given us a grant, got Jasmine a grant that allows us to offer 4 free one-on-one counseling sessions with either Rhonda or one of the other counseling agencies that we use on the island to go through grief, anticipatory grief, because you might actually have it from before the person has passed, because you know what's going to come and you're worried about it, or you're anticipating what's going to happen. And so thanks to R3, we have that, and it's open to anyone. They don't actually have to be a patient of ours. They don't have to have had a family member that's lost through our care, but anyone on the island is eligible by sending an email to us and requesting that one-on-one. They get 4 free sessions with the potential of 4 more if the counselor agrees that they need those extra 4. And then from there, we also have, shameless plug, our memory circle, which is a group setting where we meet online and people can go through scenarios such as what would I do on a bad day, or someone's anniversary is coming up, and the grief, the monthly grief coaching that happens to the group allows people to kind of get practical tips on how to manage the grief and the loss of a loved one.
Yes, I was actually, you beat me to it because I was just to jump in to say the same thing. And I'll just add that the next memory circle is actually this Wednesday coming. And it's a great, safe, confidential space for you to honor and, celebrate your loved ones as well, amongst others that are in that similar, grief path as well. So really, if you know anyone that would benefit from that, please have them, reach out to Jasmine. It's one of the programs that I actually work with Jasmine to help facilitate.
For our service, I guess it's mainly physician referral is how we would get most of our referrals sent through. So a lot of, especially like oxygen, something like that, is a medication essentially. So you would have to have a prescription written from your doctor in order to get home oxygen. Same with pressured therapies like ventilators and CPAPs, BiPAPs, again, a physician order just because it is applying pressure to the lungs. So usually we say, if you're unsure, the safest way is to just send us an email at respiratory@hsa.ky, and we're happy to kind of guide you to whether or not we can help you out without the physician referral, or we can actually assist even getting that order and talking to your GP to get all the referrals that you need in place.
Perfect, awesome.
So basically it's never too soon to come in to receive massage therapy treatment because we can treat at all different levels of chronic illness. So basically we are looking at symptom management when you're dealing with chronic illness, and ultimately we are trying to improve the overall quality of life that a patient is living. And sometimes that is simply just comfort care. Sometimes that's trying to actually improve mobility so that somebody can actually get up and mobilize a little bit better. That's going to help stimulate a lot of circulation in their body. It's going to have a lot of benefits. But we are looking at ideally preventing your symptoms from getting worse. So the sooner that you're able to come in and start doing regular maintenance care, the better. And it's also never too late. I've worked with patients right up until end of life, and the treatment looks very different at that stage than it would early in the disease process. But we adapt our treatment as you go through. As for referrals, unfortunately, we are also not covered by most insurance companies on island, but we are hopefully going to have that changing soon. But we do work directly with your healthcare provider. And if you are suffering from chronic illness, they can send over a referral with some detailed information for us so that we can better, more accurately treat the patient from a whole perspective.
Okay, so with acupuncture, we're quite fortunate here that a lot of insurance companies do cover treatment. I get a lot of people that come by themselves. It's never too soon, it's never too late. Speak to your doctors. There's a few doctors on island which are wonderful doctors, and it's really nice for me to see because I'm not used to this in the UK, but a lot of people are very promoting of acupuncture and realize the benefits of complementary health. We also have a wonderful reception team, so if there's any confusion on what would be covered, what's not, please just give them a call and speak to them and they'll help you out.
One quick question for Ashley and Gavin. Do you guys go to the homes at all, or are your services only offered in your facility?
So originally, actually, Cameron Massage started as a mobile company, but we are now located in a clinic setting. We ideally will operate out of the clinical setting just because all of our amenities are there to incorporate the full treatment. But at end of life, sometimes that's not possible to come in, or as chronic disease progresses. So that is something that we can do is go to the homes and provide care at home.
Yeah, at the clinic down in Pastoral Place, or I can come to the home. I'd also like to speak to someone about coming to do something at Jasmine as well.
We love that.
So,
Awesome, perfect. Any final questions? We're just about at time. One last question and then we'll wrap up.
Rachel, so one of the questions that we do get sometimes is, can I have oxygen? And most of the time we do say no because they don't need it, but that's the usual thing. From a palliative perspective in the home, I mean, what would be a better response? Or is that the right thing to say? Like, we always explain to them, like, if you don't need it, you know, we're not going to give the oxygen. It can actually may even do more harm than good. But then of course they get into that loop that you talk about as well. So just want to have, I guess, an idea of how to maybe better respond, or if we're maybe responding okay, or you know?
Yeah, that's a great question. So I find most of the time, if your breathlessness is not caused by a low oxygen level, the oxygen isn't necessarily going to improve that breathlessness. So it is one of those things that sort of a rule of thumb is we always have your oxygen saturation either greater than 88% or greater than 92%. If it's less than that, then we would consider putting oxygen therapy in. There are certain rules that we sort of play on in order to say if you qualify for home oxygen or not. We don't tend to make patients qualify at end of life. So there are occasions where their saturation might be above 88 or 92%, but they do feel the benefits of oxygen. And in that case, the harm of oxygen isn't necessarily a concern for us. So we would allow them to have oxygen at end of life. So it's kind of a hard question because it is per patient, but we always try to start with things like breaking that cycle of anxiety first, because a lot of people actually feel the benefits of oxygen. It's more of a placebo effect than anything. And if we can come up with some other ideas to try and help the breathlessness, like deep breathing exercises or inhaled morphine or morph, I think is what you guys use a lot in the community. Those things actually help a lot more than the oxygen if it's not breathlessness due to a low oxygen level. So I would say at the end of life stages, if it is something that is a concern for them, we're happy to come out and give a trial and see if it's going to make or break or benefit them. But otherwise, having trying all the other sort of additives to go along to break that cycle of breathlessness first, and just reminding them it's, you know, it won't necessarily fix that shortness of breath unless the shortness of breath is caused by the low oxygen. And that's just something a lot of people don't understand.
Thank you. We got one last question from our visiting doctor.
Hi, I'm Dr. Khan, palliative care physician in Boston. This is actually more of a comment piggybacking on the question you just asked. So I definitely agree. We do have evidence, data that basically shows that there's no improvement in the sensation of breathlessness when you give somebody oxygen who doesn't have a low oxygen. So you can give all of those explanations, but they're cognitive, and it really goes back to what palliative care and communication is really about, is what that patient is asking you is not, I want oxygen. They're saying, I'm short of breath. And what they're wanting to hear is, are you going to help me feel better? I can't breathe. What can I do to breathe better? And yes, you can give the data about oxygen doesn't help, but you have to reassure them that I hear you, that you can't breathe, and that we're going to figure out how to help you do that. In some cases, oxygen is the thing that can help you do that. In your case, it is not oxygen, but these are the other things. And you talk about what our respiratory therapy colleagues do so very well. Sometimes something as simple as a bedside fan, or being next to fresh air where you're blowing air on the face. It can stimulate one of the nerves and can help with that sensation of breathlessness. We know that low dose opioids given chronically can help with breathlessness, but it goes back to really when patients are asking some of these things, they're not necessarily asking for a particular treatment, because that treatment is just a process. They're asking for an outcome, which is, I want to feel better. And we can explain, we're not going to abandon you. It may be difficult, but these are all the other ways that I can use to help you feel better.
Thank you. That is a great summary of that answer to that question. Unfortunately, we are out of time, even though I'm sure I could find another couple of questions for you guys. I want to say a huge thank you to each one of you guys for taking the time to come. Bags? We have a little thank you for you, but I haven't brought them in yet. But yeah, thank you guys each for coming. It was an early morning. We know from Jasmine's standpoint that there's a huge benefit for supportive services in regards to treating the whole person. And our aim from this conference, and Jasmine in general, is always to think whole person and not just the medical side of it, not just giving the medication, not just treating the blood levels, but looking at the causes behind it. And I think each one of your disciplines speak to looking at the causes behind it with the goals and the hope to ensure that we can really manage everything to do with the patient and the family through a very difficult and sometimes long-lasting chronic illness or that end of life stage. So thank you guys so much for what you do for the community, for Jasmine, and for taking the time to come and present to us. We're not going to take a quick break, but if you have to grab a coffee, grab it and come back. We're going to go straight into our next presentation. It appears so. Give them 2 minutes. Yeah.
Say, okay, I see some people are going to get a cup of tea or coffee, so we'll just wait a couple of minutes till they come back. I get one myself. Is everybody ready to get started? I'm getting a message that we got to get on. Yeah. Okay, so I'm now going to introduce one of our two speakers for this morning. And those of you who are here yesterday, you'll have to excuse me repeating, but I just want to give you some background on Dr. Shapir Rosenberg, who is going to be talking about such an important topic: old problems, new ideas, advanced planning for dementia. And dementia, we see a lot of patients get referred to us with various types of dementia. It is a huge burden on families, on the community, and it is only going to get a bigger problem as time goes on, as our population ages. So I'm going to just give you some background. Dr. Rosenberg is a palliative care physician and psychiatrist. He graduated from the University of Pennsylvania with a Bachelor of Arts in Philosophy. He completed his residency at the University of Maryland Medical Center, where he was inducted into the Gold Humanism Honor Society. He then completed a fellowship in hospice and palliative medicine at the University of South Florida, and is not a palliative care physician, and is now, sorry, a palliative care physician and psychiatrist at Forbes Hospital. End of life care, teaching, and the medical humanities. And from the two presentations he's already given to us, we've all learned such a lot, and we're very fortunate to have him here. So welcome, Dr. Rosenberg.
Okay, good morning, everyone. Hopefully today's presentation will be a little more relaxed than yesterday's, where I was rushing to get through some things. There's no PowerPoint today. We'll talk about some things, and then we'll look at the document that you all have in front of you that's stapled and is called "What If I Had Dementia? Planning for the Future." So first, I'll make a couple comments. Why I do palliative care, what an advanced directive is, what makes dementia unique, and then this dementia-specific advanced directive. So I do palliative care, and I think, oh, I have a question already. No, okay. With the trade-off of no PowerPoint is I also don't have any poems for you today like I did yesterday. I know that was a crowd favorite. So, okay. As I shared with some of you who attended the lunchtime talk about the potential applicability of palliative care in psychiatry and certain severe psychiatric disorders, I do palliative care because I came to see in very personal terms how dying matters for the person who's dying, and how dying matters for the loved ones, the family and the friends who continue on after that person's death. My mother died when I was 12 years old of breast cancer, and she was 48, and there was no grief therapist, as I was delighted to see on the panel just a bit ago. There was no grief therapist who counseled me or counseled her through an anticipatory process or me in the aftermath of it. There was no hospice team that was involved. And I simply came to see how I think her death could have been better and how my life in grieving her death could have been better and different in the aftermath. And so my motivation in palliative care is a deeply personal one, and I wanted to share that. I didn't have an opportunity to do that yesterday. Raise your hand if you've cared for someone with dementia. Raise your hand if you've cared for someone with dementia. Okay, so a lot of hands go up around the room. I don't have the statistics, although you can easily enough Google the prevalence of dementia worldwide and and frankly, the growing anticipated incidence and prevalence of dementia. Simply to make the point that this, unlike some more niche diagnoses, rare diagnoses, dementia is not a rare diagnosis. It's very, very common. And it's an illness that we see in psychiatry, we see in geriatrics, we see in neurology, we see in internal medicine, of course, that can span and endure for years, for many, many years, from the first early manifestations of it through to the very end stage dementia processes where a person is bedbound and nonverbal and sleeping 23 hours a day. So that process can span years and decades sometimes. And in that way, it's actually somewhat unique in disease categories. Okay. A comment about what an advance directive is. I presume most of you choosing to attend a conference like this are familiar with an advance directive, but an advance directive quite simply is a document used to guide care in the future. Okay, some are legally binding, and I'm no expert in Caymanian jurisprudence, but in some countries and in some regions of some countries, they're more legally binding than others. But it's at its core a document that's simply used to guide care. It, of course, does not and cannot cover all possible scenarios. And as a palliative doc, part of the reason I have a job is sometimes the nuance of what to do and when to do it and what not to do and when not to do it is so patient by patient specific that no single document can anticipate all potential future scenarios. And rather, it's simply used as a general guide. In my experience, family members often take tremendous comfort in saying, well, Dr. Rosenberg, I'm glad you asked about the advance directive. And yes, my father, my grandfather, my mother, my grandmother drew up this document, and she makes it abundantly clear to all of us that she does or does not want this, that, or the other. And often that general guide is, as psychiatrist, helps in the anticipatory grief process and then the subsequent grief process when that person passes, in terms of did they or did they not honor the wishes of the person who died as regards medical interventions for them. Okay. Now, what makes dementia unique? Unlike other illnesses, typically, like cancer, like heart disease, like kidney disease, where a person generally retains what I would call global medical decision-making capacity up until the very, very end stages, dementia takes that away. And dementia takes that away often quite early in the illness. So let me say that again. A person can have cancer diagnosed at whatever stage, but likely that is not impacting their ability to assent to, to agree to, or to decline various interventions ranging from daily labs while in the hospital to major surgeries, feeding tubes, CPR, etc. A person's cognitive capacities are generally intact. That is not often the case in dementia. That would almost never be the case in dementia, and certainly not in a moderate or severe dementia. Capacity is a whole other topic that we won't have time to attend to. Physicians generally are the ones, and often physicians will call in their psychiatrist friends to do formal capacity assessments to decide whether a person can or cannot make decisions to assent to agree to, or to decline various interventions. And there are various measures by which we do that. Again, I won't be sort of delving into that now, but the bottom line is dementia, sadly, takes that decision-making capacity out of the hands of the patient themselves. When a patient loses decision-making capacity, I should add, decision-making capacity can be global and it can be specific. So a person could be deemed to lack capacity to make a decision regarding heart transplantation if it was felt that they really do not understand the implications of that, for instance. But a person with that who was deemed not to be able to make a decision about a heart transplant could nevertheless be deemed to have capacity to agree to or decline daily labs. Sort of the bar moves depending on the intensity of the intervention. Okay. When a person loses decision-making capacity, whether about something small or about something large, decision-making capacity then defers to a surrogate decision maker. Okay. In formal legal terms, people can draw up healthcare proxy documents. And so a proxy is someone who is deemed by a legal document to be that person's healthcare surrogate. A healthcare surrogate is a more general term when a person has not designated a proxy, and often, at least in America, it's state by state. Each state often has a rank order list of who gets to make decisions if a person did not assign a person and now can't assign a person because they've lost their cognitive capacity. And typically it's a spouse, and then maybe a person's child, and there's sort of a rank order list that just moves on down. Okay. So what I'm sharing with you now, the crux of my talk, is something that I did not lay any claim to having invented, but I think is novel and worthwhile to present. It came out in 2017. It was created by, as far as I can tell, 3 physicians in the Seattle, Washington area. And it's a dementia-specific advance directive. To my knowledge, it's the only disease-specific advance directive. And by that, I mean, it encompasses the various stages of that illness, and it's tiered in terms of what a person might or might not want at each stage of that disease. So you'll see what I mean by that in a minute. Or you'll see what I mean by that right now. So let's turn to page 3 of the document. By the way, this is you see the copyright at the bottom says it's okay to use for non-commercial purposes, which is what this is. This is simply educational exercise, and it's freely available on the web. I just had Felicia print some copies for all of you. So turn to page 3, and if you quickly take a look, page 3 at the top says stage 1 mild dementia. Page 4 at the top says stage 2 moderate dementia, and page 5 at the top says stage 3 severe dementia. Okay. So here's where, again, I'm sort of making a distinction between dementia and other categories of disease. A person could be diagnosed with cancer, stage 1 cancer, stage 2 cancer, stage 3, stage 4. But at all of those stages, a person's capacity for medical decision-making might be fully intact. They might be fully intact. So in no way does their stage of, in this case, cancer diagnosis, or it could be a stage of heart failure or a stage of kidney failure, impact per se their cognitive capabilities, i.e., in this case, manifesting as their decision-making capacities. That is not the case in dementia. If we look at the top of page 3, and there's sort of a nice little blurb about it's sort of a succinct description of how a person at each of these stages manifests in terms of their dementia. We'll take a look, we'll read this out loud, and then we'll sort of walk through the scenarios that the check boxes don't change across pages 3, 4, and 5. What might change would be what you or your relative, your loved one, would want, depending on the stage of their illness. Okay. So stage 1, mild dementia. With mild dementia, people may often lose the ability to remember what just happened to them. Routine tasks become difficult, such as cooking. Some tasks can become more dangerous, such as driving. And then the question that is asked across pages 3, 4, and 5, meaning across mild, moderate, and severe stages of dementia, is if you were to be at this stage, what medical care would you want or what would you not want? So the person with mild dementia is able to talk, is able to walk. They might not remember where they put their keys. They might not remember how to do complex tasks like cooking. Cooking is a nice example because it involves a lot of planning. One has to sort of know where one is trying to get to in order to recall the steps necessary to get there. Driving can become an overwhelming experience where people will simply forget to look one direction or the other, or forget rules of the road, and these sort of common things that we take for granted, they lose. Okay. So let's just look at the boxes. Now, as a palliative doc, there are far more than 3 boxes that can be checked. And there is so much nuance to what a person does and does not want. But these 3 boxes give a big picture overview of if something happened, and we'll talk through some of the things that can happen, what would a person want? And now the idea I think to keep in mind, and what is unique about this document and why I think it's worthwhile to share at a palliative care conference, is I'll make it direct to you, would your wishes or would your loved one's wishes change based on their stage of dementia? Would that change based on their stage of dementia? For instance, if I have mild dementia and I'm walking along the street and I have a heart attack, and you're walking with them, let's say, and you happen to have a document with them that would say yes, CPR, no CPR, would you want that person to have CPR? Meaning, and we'll put aside the talk about the odds of success of CPR outside of a hospital and the odds of success even inside a hospital. But let's say a person has a heart attack. Would you want CPR potentially to recover back to, and now the odds of this are also are somewhat questionable and low, but would you want CPR in the hopes of recovery at that stage? And might now that be different if a person has an advanced dementia, is already bedbound, is perhaps already nonverbal, is perhaps is totally dependent on others for all their activities of daily living, their toileting, their bathing, their feeding, etc. Would you want CPR in that circumstance? So that is the intent of this document, is to draw out those potential distinctions. Okay. And of course, a person, though, with mild dementia can't necessarily say or make these decisions. And so to do this now, before a person develops dementia, is the key part here. So the 3 boxes are: big box number 1 here, to live for as long as I can. I would want full efforts to prolong my life, including efforts to restart my heart if it stops beating. Okay. So to me as a palliative doc, that means full code. They want everything and anything that's necessary to resuscitate and then to sustain life thereafter. Big option number 2, big box number 2, is to receive treatments to prolong my life, but with some caveats here. If my heart stops beating or I can't breathe on my own, then I would not want my heart shocked to restart it, and I would not want to be put on a breathing machine. By breathing machine, we mean a ventilator, we mean a respirator. That's all the same terms. And in parentheses, that means do not resuscitate, DNR, and do not intubate, DNI. Okay. Instead, if my heart stops or I can't breathe on my own, allow me to die peacefully. Okay, so big option number 2, and this is sort of Often the emergency room doctors are the ones asking this question, distinguishing between box number 1 and box number 2. If a person comes in with a myocardial infarction through their doors, is yes CPR or no CPR. That is a big fork in the road. That's a big fork in the road. And CPR means chest compressions, sometimes shocks, sometimes medicine, and intubation, i.e. breathing machine. That's what CPR means. Okay. Why might someone choose that middle territory? So the document says, if your mind were already not working well due to dementia and something suddenly happened which stopped your heart or made you unable to breathe on your own, the chances are high that even if you survive the ICU, your brain might be more damaged. So some might say, if I would likely be worse off, even if I survived, then I'd prefer just to die peacefully. Okay. Now, so that middle box would suggest, okay, I wouldn't want CPR and I wouldn't want all the things that CPR connotes, but I might be okay with other things. I might be okay with other things. Should I develop those other things? Those other things could be a need for dialysis. Those other things could be a need for IV fluids, for IV antibiotics, for blood pressure support medicine, what we call pressors, for hospitalization at all. I might be okay with being hospitalized. I might be okay with various surgeries. Okay, so box number 2 is a way of saying, I'm okay with lots of medical interventions, but CPR, chest compressions, being intubated and being put on a ventilator, I would not want. Okay. And then big box number 3 is comfort care only, comfort focused care only. So it says, of course, including DNR and DNI, I would only want medical care to relieve symptoms such as pain, anxiety, or breathlessness. I would not want care to keep me alive longer. The antibiotics that I just mentioned the intent is to keep someone alive longer. Dialysis that I just mentioned would be to keep someone alive longer. Box number 3 says, I don't want that. It would be important to me to avoid sending me to a hospital or emergency room, what we call DNH, do not hospitalize, unless that was the only way to keep me comfortable, because trips to the hospital when someone has dementia can become quite traumatic. Okay, so that's the big picture. Now as palliative doc, I can come in with a far more sophisticated list of interventions. Sometimes I actually do, and we sometimes go through the list. Or sometimes, and maybe more importantly, I try to get a general gestalt of what a person wants or doesn't want, what their family member thinks that person wants or doesn't want. And then we sort of complete the checklist together. This is a general checklist that has 3 big picture options. Okay. Now, we can turn the page to page 4, the moderate dementia. And the only thing that changes here is that now instead of having a mild dementia, a person has a moderate dementia. What things would a person want or not want in that setting? Nothing else about the page changes, meaning nothing else about the options changes here. So in moderate dementia, communication becomes very limited. People lose the ability to understand what is going on around them. People require daily full-time assistance with dressing and often toileting. They can sometimes become quite confused and agitated and paranoid. Some people appear to be content much of the time. Okay, so this is actually a stage that we in psychiatry see a lot. It almost sometimes ends up being a toss-up whether situations like this go to psychiatrists or neurologists. But we see people as they move through from mild to a severe dementia with manifestations with symptomatology, including agitation, including psychosis, including depression, and can be actually tricky to tease out where's the depression coming from. Are they depressed because of something that, well, are they depressed because of reasons that a non-demented person might have for becoming depressed? Or is the depression somehow a direct consequence of the dementia process itself, or in some nonverbal ways, their way of actually telling us that they're getting sicker and that in some deep way, they actually are aware of it themselves. Anyway, this moderate stage, it's hard to define. It's best easily defined as between mild and severe. People can still be ambulatory. People can still talk, but that conversation can sometimes be nonsensical. It can be illogical. People cannot typically follow a conversation. You could have the person with you at dinner, but there's really little to no understanding of what's being discussed. Okay. All the same questions. All the same questions. What would you want if you now have moderate dementia? And I think the idea behind this is the odds, as I present to people, of resuscitation, restoring a person back to how they were, is low. Let me take a step back. The odds of resuscitation working at all are low. The odds of resuscitation bringing a person back to how they were is even lower. Okay, so even if resuscitation works, the odds of them being brought back to the state that they were in before they, for instance, had the cardiac arrest is exceptionally low. And so going into this, and now this is an opportunity for all of us without a diagnosis of dementia to say, you know what, if it comes to that, I do or don't want this, that, or the other. Okay. Why don't we turn to page 5, the severe dementia. Okay. In severe dementia, people are no longer able to recognize loved ones and family members. Some people with severe dementia may be calm and serene much of the time, but many go through periods of rather severe agitation. That's often a lot of family members will bring a person to the hospital and they actually end up being admitted to the psychiatric unit. Ideally, if there's a geriatric psych unit, that's better, to frankly give antipsychotics to help manage the severe agitation, sometimes the paranoias, the hallucinations. We see that a lot. They can be awake through the night. They can be, often their sleep-wake cycles are completely disrupted. They can be angry, disruptive, and yelling. People need 24-hour help with all ADLs, including bathing and assistance with all basic body functions. Okay. And I would say in very end-stage dementia, really sort of terminal dementia, people are bedbound, nonverbal, and are asleep the vast majority of the time, 20 hours a day, 22 hours a day. Is not at all uncommon. Okay, and now all the same 3 questions. All the same 3 questions. What would you want? So a person with an advanced dementia laying in bed, perhaps at on home hospice. Some hospice agencies will allow a person to remain full code, others will not on home hospice. Person with advanced dementia has a heart attack. Family can panic, can call 911. 911 arrives. Should they do CPR? Should they not do CPR? That is the intent of this. Again, because the thought, even the odds of surviving exceptionally low, and the odds of surviving to come back to their baseline, which already was an advanced dementia, also low. And one could pose the question, why? To what end? And especially if to what end involves a passage through the ICU, being intubated. Again, this is in a bedbound, already nonverbal patient with an advanced dementia. Okay. So that was our little walk through this document. Again, I think this document is unique in that it affords a chance for all of us before a dementia process begins, and while we still have decision-making capacity, to think, should I develop a dementia? At what stage would I want what intervention? At what stage would I want or not want any of these interventions? Some people, by the way, you should not think there's some hint underlying pattern here of mild, do everything, moderate, pick box 2, and severe pick box 3. There's none of that. Some people, some relative with severe dementia, cardiac arrest, yes, Dr. Rosenberg, do everything. Intubate them, chest compressions, pressors. If they need dialysis because their kidneys start to fail while in the ICU, do it. I don't care, whether for religious principles, whatever it may be. there are families that desire that. And others, mild dementia, would say, again, from the get-go, meaning if I were to fill out this paper for myself today, you know what? If I develop a mild dementia and my heart stopped, just let me go. I don't want any of that. So there's no sort of reading between the lines of, for stage 1, we should pick box 1 and stage 2, box 2, none of that. Okay. Okay. Again, to my knowledge, this is the only disease-specific advance directive. You can, in theory, check boxes. There are long advance directives that you can check boxes about what you would or would not want, but sometimes the scenarios become so nuanced as to make the advance directives nothing more than a general guide. Okay. Big picture, I think more important than this handout is the discussion that this hopefully compels between a person and themselves and a person and their loved ones. So frankly, I could assign all of this to all of you. I could assign this to all of you as homework and say, today, due by 6 a.m. tomorrow, you must all complete this. And the importance would not be completing this. And I think on the next page, there's some frequently asked questions, including whether there's any, legal bindedness to document like this. And I think the answer is no, but it's simply a guide. And I could say, well, we all have our decision-making capacity today. We won't take today for granted and do this. And so do this, sit down, ponder between you and yourself, and then share your conversation with your family and your friends about what you would and would not want. Of course, this applies to dementia. This applies to dementia, but of course, this applies to everything else too. And I think the hope is that this, like so many other movements in palliative care, including organizations and movements like the Conversation Project, all try to encourage people to think about these things now in advance before they end up in the emergency room with a palliative doc calling them and saying, we need to come in now, we need to talk about some and make some very important decisions that are really pressing. Better to have this done in advance if at all possible. Maybe I'll just pause there and see if there are any comments, questions. Again, a little less hurried than my talk yesterday. I could just focus, please.
Hold on quick. Oh, the other one is.
If you worked in a jurisdiction that is legal for euthanasia, would you add a 4th box?
So as philosophy major, I can think of lots and lots of philosophical and legal and bioethical issues that you of course raise, and which I presume are behind your question. I'm not an attorney. I would, and we'd have to parse out what you mean by euthanasia. I'm going to give you an unsatisfying answer because in part of the vagueness of the question. If by euthanasia you mean places where MAID, medical aid in dying, is legislated. So medical aid in dying in some places is a way by which a physician, not administering a lethal dose of a medication, but rather writing a prescription for a lethal dose of medication that a patient then consumes themselves to bring about their end of life. First, I'm going to say I don't know the answer to that. Second, I'm going to say I suspect that the current protocols, particularly in Canada, as regards MAID, require not surrogate decision-making, but rather patient themselves to undergo a capacity assessment, often a multi-layered one with multiple physicians, where they themselves, and not a surrogate, elect for MAID. This process is a document where a patient who has full capacity can make decisions which a surrogate then has to enact, has to dictate, has to state to the physician this is what so and so, short of having a healthcare proxy form, which delineate what they might or might not want. This is what this person would have wanted, doc. So please respect that. So I can't see a scenario at the current time. I'm not familiar with how things are in Europe, where the processes seem even less restrictive. But at least in North America, to my knowledge, there would not be a fourth box for medical aid and dying on a document like this. Yeah, good question. Yes, thank you.
Thank you for your talk this morning. I think it's particularly relevant, meaning the topic of dementia, when we think about the population of the Cayman Islands. And so we've just gone through the process, and you and I discussed this a little bit last night. We went through the process of completing our census. And when we look at the results of the census in terms of population growth, the fastest and largest growth in the population by age is the 65 plus group here in the Cayman Islands. Over the last 11 years, it was a shock. I reviewed the numbers again this morning, a shocking 97% growth over 11 years. The second largest age group in the Cayman Islands in terms of growth is the ages 50 to 65. And that was 79% growth. So we are on the cusp of the silver tsunami, if you will. And so dementia is going to increasingly factor into our healthcare environment and healthcare decision-making. So I think this is extremely topical and very relevant, and for healthcare providers, for families, for caregivers, and patients themselves, really need to start thinking about this as we move forward into this this growing aged population.
Thank you, Fiona. As I recall, there was sort of a fuzzy memory, but there was a jurisdiction, I think in Minnesota, that mandated, I can't quite remember how, and I don't know that there were sort of legal repercussions if it wasn't done, but mandated that all of its citizens of its county complete advance directives with their primary care physician, no matter their age, with illness, without illness, complete advance directives. And one could envision, it's sort of touted amongst the advocates of advance directives that the small and large populations ought to complete these forms in the sort of comfort and the non-hurried, ideally non-hurried setting of their primary care doctor's offices, so that their physician, so that they know what they want, their physician knows what they want. These conversations have been had with family and friends, and that's established so that far in advance of anyone actually becoming ill with any manner of disease. Yeah.
So how often do you actually see somebody with the mild dementia? Because I mean, obviously us being in the medical field are quite know that we wouldn't want to, or what we would like in terms of directives, but it's hard to have that subject sometimes with your family members. And I'm speaking from experience. So my mom, it was probably 8 months after my dad passed away. And her what she first showed signs of was just moving the keys to the wrong place. She was in a 4-bedroom house. She was walking her dog twice a day. She was bathing. She was talking. You'd have a great conversation. She didn't repeat herself either. So when she mentioned, well, I've always been a little bit forgetful, I took her, just thought, well, we'll just, she's been 8 months here now in the home by herself since my dad passed away. We went and did the testing. That was actually after she just got her driver's license renewed at 86, moderate dementia. She was the first person out of the class at the driver's test, passed with flying colors, right? So when she got that diagnosis, we went back to the doctor and I said, okay, well, what can we do? And so we're sitting there and he's saying to my mom, well, you have moderate dementia. You're going to probably need some assistance. And her response was, when I need assistance, I'll ask for it. Like she was not buying into it, not with him, not with the gerontologist. And I left that meeting and went home and I thought, well, if this is what moderate dementia looks like, it's not too bad. She's still driving, she's cooking, she's walking the dog, she's dressing, she's bathing. It's just this a little bit of forgetfulness. But what I found with that disease process, my experience, and it may not be for everybody, is it was this plateau and then it was a snowball. And then it was a plateau and then another snowball. So she did well for the first little while. And then she started exhibiting the driving on the wrong side of the road, that I had to stop everything and have her admitted and take over care. I could never have had a conversation with her about what are your directives at this point. She was in full control of what she wanted or didn't want with her life,
You're saying, to your last point, she was in full control,
making the decision making.
even with the moderate dementia
Yep.
Diagnosis.
Yeah. The doctors
So-
didn't say you can now, take over that area
Okay.
because she's still functioning at home and making those decisions making. And for the most part, there was nothing that was wrong with her decision making.
First of all, thank you for sharing
Oh.
about your mom. It's a challenging question, which gets to, of course, or what I think might be some questions in there. How do we delineate mild versus moderate dementia? What does it actually look like to take decision-making away from someone who is still walking, talking, eating, and often very much in control and liking to be in control of their lives? Ultimately, I'm going to a bit pull rank and say a physician, well, I'll maybe hearken back to when I mentioned that sort of moving bar of if, let's say, your mom needed, I don't know, dialysis. Suddenly she were to develop kidney failure and require dialysis, and not acute dialysis, but a chronic and ongoing dialysis. As opposed to her going to her PCP and the PCP saying, I need to, check your thyroid levels. Can I do a blood test? So I want to harken back to that. The bar for capacity can move, should move, in my view, depending on the intensity of the intervention, depending on the severity and the potential complications that can come with an intervention. Doing a blood test to check a thyroid level, low risk, high benefit, kind of a low bar for capacity. Starting someone on dialysis who will then perpetually need dialysis, higher risk, questionable benefit, especially at a certain age and with certain diagnoses, and so a higher bar for capacity. I might then, frankly, grant some license to the physician to say, I know, ma'am, that you're in control of your life and that you are able to manage most of things on your own. But nevertheless, I, as physician, based on a conversation, of course, and a capacity assessment, do not see that you fully understand XYZ about what we're discussing. And so I'm going to defer to a surrogate, but potentially you. Now, of course, to do that compassionately, to do that humanistically, to do that, how much does a person need to? That's the nuance and the art of it. And so to have a private conversation aside with you about yes, dialysis or no dialysis, would your mom be the better or worse off for not attending to that meeting? That would be a question one could consider. So I guess my response to is simply one, these are of course the difficulties of when people transition from no dementia to a dementia process, from a dementia process to a worsening dementia process. When and how do we take decision-making capacity away? Do we, as I tried to make clear, not take it away in a global sense until far later stages, but rather, would you be okay with, us taking your blood? Yes, okay, kind of good enough for, I think, most docs without having to do a whole big formal capacity assessment about a lab draw, but a bigger capacity assessment when it's big things like a CPR question. So a doctor, your mother's PCP or your mother's neurologist or psychiatrist who is helping manage the dementia might say, you know what, I'm willing to try to have a CPR discussion with her. I'm willing to try to walk through this form with her. And in the end, if I doctor don't feel that she understands this adequately, I am going to defer to you. period. And so that's the physician's professional obligation to do that, more than simply a matter of one need not sort of walk on eggshells. One has to, as physician, professionally be assured that a patient understands what we're discussing. Hope that's somewhat of a response. The challenge of your situation is duly noted.
I think that's all for questions and also all we have time for, but
Okay.
he will be back in the hot seat at the panel discussion a little later than this. So if you think of those questions and you didn't get it asked this time, you can ask it again at that time. And I will pose one other one for you guys to think about, but you're not going to answer. We're just going to think is that I think what we could definitely have as another one on that or broader discussion on would be tube feeding and artificial feeding in regards to dementia patients and as they deteriorate, and having that discussion a lot earlier with people so that they can understand and not be at that crisis standpoint, deciding whether we should put a tube in or not put a tube in, and how that affects the end stage with CPR and quality of life as well. So just something to think about. Thank you.
Thank you, Felicia.
Thanks very much, Dr. Rosenberg. As I said at the beginning, and Fiona mentioned, the silver tsunami is already here and we see it. We have a lot of referrals for dementia. So this is very, very apt. And I think Felicia's point to the other interventions, which are not as easy to decide on as CPR, will be coming to. We're very fortunate now in the Cayman Islands that the medical decision-making law was passed relatively recently. And we actually sat on the steering committee to get that enacted, because prior to that, your wishes could be overturned by your relatives after you became, unconscious or unable to communicate. So I was just asking Felicia to tell you that, or to give you the website, on the government website, if you want to download the advanced directive form. And what is it called? dip.gov.ky, Healthcare Decisions Law 2019. And in that, there's a document. And I have gone through it with several patients, and they keep a copy on their file with me as their primary care. They keep a copy themselves. They might put a copy with their lawyer. And I usually encourage them, if they can, and they already have their file at the hospital, to keep it there, because if they get taken there by ambulance without their loved one and they are in that situation, then they will be resuscitated. Or if it's already entered into the system, then the people in the emergency room will know that in advance. So thanks, Dr. Rosenberg, again. I'm now going to introduce Dr. Oh, hang on, she's disappeared with my thing. Here it is. Dr. Donna Thompson, who is an oncologist who I met many years ago when we were both teaching at St. Matthew's Medical School. And over the years, she has supported Jasmine and palliative care services in her career, and here with us, to a great extent. She's had 30 years of experience in medical oncology and hospice practice. She studied medicine at McGill University in Montreal and did her residency at both McGill and Maine Medical Center, Tufts University. She did her fellowship at Maine Medical Center, again, Tufts University, and Dana-Farber Cancer Center, Harvard University. She went on to practice medical oncology at Lewiston, Maine for 30 years. In 1969, she completed a hospice internship and had the privilege of meeting Dame Cicely Saunders, the founder of the modern day hospice movement, and spent time at St. Christopher's in London and Hunters Hill in Glasgow. She is currently the Associate Clinical Dean of the University of Medicine and Health Sciences in St. Kitts, and also in New York and South Portland, Maine. She has previously taught at St. Matthew's in Cayman and taught clinical medicine with myself. And we have always invited Donna to our conferences, and she usually gives us a very different way of looking at things and rounds things up for us. And so we're really delighted that she's here with us again after a 2-year absence of COVID. So welcome, Donna.
Let me just say one sort of personal thing as an observation. I really love the Cayman Islands, and I've been coming here since 1987, and originally strictly as a tourist, but then got involved in other things like St. Matthew's and hospice. And it reached the point where I was almost more happy to come here to do those things than to lie on the beach. On the other hand, because of COVID, we had not returned for 2.5 years. And both my husband and I were so disappointed. And I have to tell you, when we landed the other day, flying down 7 Mile Beach and finally hit the ground at the airport, I was getting all choked up because it was just so great to be back. What I'm going to do today is refer back to some of the previous speakers and kind of tie things together and give it, I won't say a whole history of the hospice movement, but a couple of maybe anecdotes of where we've been and where we're going and how how I see some of the challenges of the future and some of our great accomplishments. First of all, let me say I'm old. I graduated from medical school in 1971. And a lot of the things, if you remember back to what some other people said historically, that's when some of this stuff started to begin. When I was a freshman in 1967, people started to talk about Kubler-Ross. And that was the in thing in the very beginning of palliative care. People didn't even really know what was palliative care, quite frankly, but everybody talked about it. Everybody had a seminar. And for a long time, people got really obsessed with the stages. And I can remember many conversations among students, caregivers, everything, or somebody admitted a patient and they'd have to have a long conversation as to which stage they were in. And they said, no, I think it's acceptance. No, they're still in anger, and people would get really obsessed with that. And although people, I think, have a lot of respect for Kubler-Ross bringing attention to that sort of obsession with following her rules, I think has disappeared. Also around that same time was Cicely Saunders and her Foundation of St. Christopher's, and really brought attention to the hospice movement, and it began to spread. Her place was sort of like the mother house of hospice. And I was really very pleased to have that opportunity to be there. And I'll tell you what impressed me about St. Christopher's more than anything else. It was very comfortable. The staff and the patients had this terrific relationship. Many patients had come and gone many times. But really shocked me, especially coming from American hospitals where booze is totally taboo. Every afternoon at 4 o'clock, they got out the drinks cart and they went around. And the doctors and the nurses and the patients all had a cocktail or a glass of wine, and it was kind of festive. And I thought, wow, that is really cool. And there are probably better things to be impressed about for St. Christopher's, but that one really stuck with me. I think oncology and hospice grew up together. And I think that it used to be pretty much that hospice care was for cancer patients. And I think one of the reasons for that was it was okay to give up on that. There were other diseases like ALS, maybe dementia, that it was okay to give up on because we didn't have anything to offer anyway. And when you think and you go back to when was there such a thing as a hospice? Well, it was kind of a monastic tradition in the Middle Ages because nobody knew anything about anything. And it was a place for sick people to go and be cared for with whatever there was. And sometimes just, a drink of water and a prayer. And then it kind of disappeared and started to come back again in the 60s. And it's very interesting that it sort of grew up together. But that's changed. And I'll come back to that point in a minute. I can remember when I was in medical school, there was no such thing as oncology. It did not exist. There were no fellowships, there were no boards, there was nothing. And it came from two sources. The hematologists were used to taking care of things like leukemia, but they didn't do a very good job. And then the surgeons got interested. And breast surgeons began to think, well, maybe we could do some chemo for that, or colon cancer. And then we began to have, the leukemias, the blood cancers, and the solid tumors. And eventually they got together and it eventually became. Meanwhile, palliative care was still there, and it was still okay to give up on cancer patients. The very first patient I ever worked up on a clinical rotation was on a third-year medical rotation. And for those of you who have worked in hospitals, you know how every morning there's the rounds, and we used to push the chart rack around, and the residents were there, and the interns, we still had interns, and medical students, nurses. Medical students really always kind of wanted to impress the higher ups, the attending. I remember one very ambitious student in my class on one of these rounds one morning said, because people quoted journals, and this guy said, in next week's New England Journal, there's going to be an article on such and such. But it really wasn't like that in the oncology world. And the first patient I ever worked up, I remember her name, it was Mrs. Fuller, and she came in with advanced ascites and was diagnosed as stage 4 pancreatic cancer. Well, I got to present her the morning after I had done the workup on her. And I said, well, she's got advanced ascites where we tap the fluid, it's got malignant cells in it. And then nobody ever wanted to talk about that patient again. As we're making rounds, as, oh yeah, that's Mrs. Fuller. She's the one who's dying with ascites. And I wanted to say something about my patient. Well, she's still a person, but nobody cared. And it really made me think, wow, we're really missing something here. So I was very, very pleased to see things advanced. And I think it was Dr. Kane who met someone on an airplane, an older woman, who asked her what a palliative care doctor was. And she gave a very nice explanation. And this woman, just hit it right. She said, taking care of people. What do you mean? That's just medicine. And I think it took a while for medicine as an institution to come back to that. Yeah, a patient isn't no longer interesting because there's no more chemotherapy left to give them, or, even if we give them antibiotics for their latest acute on chronic COPD, it isn't going to do any good. I mean, we've come a long way since then. I was very lucky that the hospital that I did my early training in was called the Royal Victoria Hospital in Montreal. And they actually developed what became really quite a well-respected palliative care unit and gave a lot of conferences over the years on palliative care. So it was for those of us who really liked that sort of thing and felt attracted to it, it was a great experience. Around this same time, oncology hit what might be called almost what we thought was a golden age. And Dr. Sanjay alluded to that maybe we had 3 or 4 drugs and people really suffered. But I was a fellow in oncology when cisplatin came around, and we developed an almost 100% cure for testicular cancer, where previously it had been almost entirely fatal. We began to treat chronic leukemia, acute leukemia in kids. And we thought, man, new drugs are going to come out 4 or 5 times a year, and this is great. And we're not even going to need that palliative care anymore because everybody's going to be cured. And of course, like any other hopeful thinking, that of course is not true. So the need for palliative care is still sort of there. I think in medical education, it still doesn't receive enough attention. And students are so eager to get all the questions right. They want to know their biochemistry and their pathology. And if the test isn't going to be on the USMLE medical license exam step 1, they don't want to hear about it. And so to try to get them at whatever level to take an interest in palliative care, very few students take electives in it. They aren't really exposed to it in clinical rotations. I had the experience of, at one point, I kind of like to do some of the artsy stuff, as does Dr. Rosenberg, and I showed the movie Wit. I don't know how many of you have seen that, but it's a terrific movie about a college professor who develops advanced ovarian cancer, starring Emma Thompson. And it was also produced by the Cayman amateur acting people several years ago. And it was absolutely fantastically done here in the islands. Maybe some of you got a chance to see it. Anyway, I showed the Emma Thompson version. And at the end of the semester, when when they write their critique of the professor, at least 3 or 4, I think they were all boys destined to be orthopedic surgeons, wrote, please use wit, lose wit. No one's going to ask about that on step 1. So we still have a little bit of making our place in the mind of the medical profession. All of us who are here clearly have an interest in this, be it a doctor, a nurse, or even lay people who just really care about this and like to be a part of the movement. So I think we have, and a lot of the talks that we heard today about where are we now show that there is getting to be a lot of growth, acceptance, and utilization of the hospice services, which is incredibly encouraging. And education-wise, we now have a fellowship in palliative care. People think about getting palliative care involved sooner, but particularly, I think, in academic centers, there's still sort of a sense of, all right, so this, and I'm going to again say cancer because that's my experience. We've given this people 4 different kinds of protocols for their lung cancer. It's time to refer them to palliative care. Bye. And that's really not good integrative care. We've heard about that a lot in the last 2 days. I think patients really would like some continued caring, not shunted off. And certainly for those of us who take care of patients, I can't stand that. I never wanted to have an academic position where I was going to, if I ran out of protocols, transfer them to other people. I think you need to go sort of through the whole thing with the patient. And that's true really for any diagnosis that you're involved with. Whether the primary physician will be sticking with the patient to the end or they go to palliative care. It's much more of a tradition for palliative care in oncology. And I think we all know that there are a lot of pulmonologists, cardiologists, primary care docs who are taking care of their CHF and COPD patients to the bitter end. That's been more traditional. However, as Dr. Rosenberg and Dr. Kine pointed out, there is getting to be a lot more interest in the role of palliative care in non-malignant diseases. Dr. Kanya actually discussed yesterday, if any of you were here, about research being done on the role, particularly in pulmonary diseases, COPD, and congestive heart failure. And a lot of people actually now doing studies and looking at the fact of the role of palliative care. Dr. Rosenberg also had presented at a luncheon sort of workshop the other day about the role of palliative care in psychiatry. And I have to tell you, for anyone who attended that conference, it was absolutely an amazing eye-opener. It certainly was for me, even though I've been a doctor for a very long time. And he had us read, and maybe some of you would like to try to find that reference because it is unbelievable, about 3 young people who ended up in palliative care for a psychiatric diagnosis of anorexia nervosa. And I think all of us who read those cases were just blown away. And the discussion of this, I mean, did anybody here ever really think there'd be palliative care in psychiatry? I think we've always thought we could, you know, take care of dementia patients, make drug addicts better. And it was very revealing. So I think this is really a very important thing that's been happening in the hospice world, of extending the scope of who is going to be involved. And the fact that palliative care really has become much more mainstream, much more accepted, despite the kids who don't like it in medical school. Used to be that palliative care people were considered a little wonky, maybe a little hippy dippy, you know, just kind of on the fringe. And that's really stopped, I think. Let me just take another quick time here. I don't want to go on because everybody's getting tired of talks. What's in the future for hospice? Well, I think continued inclusion of other kinds of illnesses. I think we've also recognized the need, as some of the panel alluded to earlier, for example, with grief counseling, that's something that's not just for the patients, that's for family members and everything. I think one of the things that sometimes is difficult is how long do people keep up with that kind of thing? Grief counseling, grief care, grief therapy. And I think two questions come up in that. Number one is, when does grieving and sadness become, and perhaps you might say, sink into depression? When does mourning and grief become pathologic? And that may be the time to call our psychiatric friends. Also, it begins, I think, many times to take on a life of its own. I knew of family members who would come into these counseling for like 10 years, and it was a big social group, oh, hi, Joe, how are you? And that can be a little much, but it's basically a good thing. But I think we do have to worry about, can it be too much? What else was going to say? The other thing that I think is coming to the fore a bit more is how we look at ourselves and our wishes in dealing with people with terminal illnesses and taking care of them in palliative care. And all of us have, and I think most people who go into medicine have a little bit of a sense of control, that they are kind of telling people what to do in many cases, and we're kind of expecting to do it. And if we have somebody, let's say something relatively more simple like hypertension, and they don't want to take their medicine, we feel really defeated, and we want to be in control, take that medicine kind of thing. And we have to get away from that a little bit more in palliative care. And Shapir read a poem the other day, and I have it written down. I don't know the exact title, but I believe it was, "What Do the Dying Want?" And if you were here yesterday, you heard that. And I think that was really great to hear, because I think sometimes we forget that. We think of, what do we want for that patient? How do we define the good death, good care, et cetera? And so I think we have been indulging in a little bit more self-examination and self-assessment, and maybe pushing that little bit of control and ego aside a bit, because I know my personal reaction to the discussion on the anorexia nervosa people is, we can't let them die. They can be cured. Wow. Anyway, so it's really, I think, kind of interesting. I also have some concerns nowadays with all this business with the fentanyl deaths, and a lot of I think blame calling and name calling over opioids and everything. The drug companies are evil, doctors are evil. I get anybody here who practices in the United States, almost every other week, we're getting bulletins from the DEA about how we should prescribe medicines. And I'm just going, oh, this is ridiculous. And it's making many, many physicians afraid of prescribing medicines. It doesn't always have to be a narcotic. There's lots of other good drugs, but I see some tendencies of people becoming afraid of being accused of over prescribing. And I've just seen a lot of that sort of fear. And I think we have to be careful that we don't forget about the fact that, there is real pain out there. And to tell you the truth, I never really saw one of my patients having a real severe addiction problem or anything. They took drugs because they had the pain. And even if they were taking, 100 milligrams of morphine twice a day, they needed it. Fentanyl patches, you name it. And I think we have to be careful that we still keep the patients in mind and not become afraid of doing the right thing by the patients. The other issue that I am very concerned about, and that may be very much in conflict with palliative care movement down the road. And one of the last questions to Dr. Shapir brought this up. What about physician-assisted suicide? And obviously there are several varieties of it where the physician actually gives the medication or the prescription for the person to take it themselves. There are countries in this world, and again, Dr. Rosenberg alluded to this, where this kind of movement is gained a great deal of popularity. I find it a very slippery slope of concern. I think that the palliative approach is far better, that we have to say that life is precious. I think a person has a right to say when they think it should be over. However, I don't think anybody, and this is getting down into my personal opinion here, I think it's not right for a patient, no matter how sick or how much they are suffering, to ask somebody else to kill them. Those of us in the medical profession have taken an oath that says, do not kill people, only do what's right. And my response has often been when somebody suggests that I, give them 10 times the dose of morphine or something, is, how dare you ask me to do that? That's against my oath, my ethics, my integrity. You want to kill yourself? That's your issue. But don't try to lure other people into it, particularly professional people. And if you add killing to the list of services that you are offering, I think that's really quite bad. Now, other people may feel different, but I really see that where these movements are growing and everything, that it should be part of the mission of the palliative care people to sort of say, no, we can take care of people. We can ease pain. We can ease suffering. There's lots of things we can do besides killing people. And I think that we should always keep that in mind and try to make our voices heard with things like insurance companies and the government, that this is not the direction we should be moving in. And I am not sure that everybody would agree with me on that. I think we need to continue to realize that everybody views death differently. Some people are not afraid of it all. Some people look forward to it. Some people are just the opposite. We really didn't in this conference talk much about the spiritual aspect of this. And I think having various types of clergy or other counselors often is very helpful to people. Obviously, other people are not religious. It's a huge spectrum there, but it's important. And we have to know that concern about spiritual life, spiritual peace is not a big part of it, just like social, physical, whatever kind of comfort you need. And I think we have to be sure that we include this. And I know that most of the palliative units and everything are very aware of this and look to patients' needs in this regard. I think it remains very important. Going back to how this affects caregivers, I will tell you that probably the most uncomfortable question that anybody ever asks me is, well, what do you believe, doctor? And I'm not a clergyman or woman. And I always kind of say to the patient, well, what do you think? I don't really see how my own personal thoughts are helpful, but I think many of us may have been in that condition where the patient or a family member is sort of challenging you to, thinking, hey, this is the doctor, she knows everything. Maybe they can tell me what lies beyond, and of course we don't. So there's many different attitudes towards death. And I've done this conference quite a few times. And I usually like to end with some poems. Dr. Rosenberg also likes poems. He and I have been friends for many, many years and share a lot of common interests. And clearly one of them is poetry. You probably know these poems, but they are very different takes on the approach to death and what death means to each of us, because we're all going to go there. And the first one is written by John Donne in about 1600. It's very old, and you probably know it. Death be not proud. Death be not proud, though some have called thee mighty and dreadful, for thou art not so. For those who thou thinkest thou dost overthrow, die not, poor death, for you cannot thou kill me. From rest and sleep, but they picture be much pleasure then from thee much more flow. And soon our best men with thee they go, rest of their honest souls delivery. Thou art slave to fate, thou art slave to fate, charms, kings, and desperate men, and dope with poison and dwell with poison, war, sickness. And poppies or charms can make us sleep as well, and better than thy stroke. Why swellest thou then? One short sleep past, we wake eternally, and death shall be no more. Death, thou shalt die. Becoming more contemporary, Dylan Thomas in 1951 wrote, do not go gentle into that good night. Do not go gentle into that good night. Old age should burn and rage at the close of day. Rage, rage against the dying of the light. Though with men at their, thought the wise men at their end, no dark is right, because their world has thought on lightning. They do not go gentle into that good night. Good men, the last waved by, crying how bright their frail deeds might have been. Rage, rage against the dying of the light. Wild men who caught and sang the sun in flight, and born too late, they grieved it on its way. Do not go gentle into that good night. Grave men near death, who see with blinding sight, blind eyes could blaze like meteors and be gay. Rage, rage against the dying of the light. And you, my father, there on the sad height, curse, bless me now with your fierce tears. I pray that you do not go gentle into that good night. Rage, rage against the dying of the light. Thanks. We're having a break first?
No, we're going straight. Yeah. Thank you very much, Donna, for bringing it all together. So, and ending with those beautiful poems, which have very different takes on death. I think poetry is an amazing comfort to people, and we do have a lot of really good resources at Jasmine, books and online things. And I think we should sort of recommend them to our families and clients a bit more, because people do write in a very poignant way, which can touch people in all their different situations that they're in. Yesterday and today, well, yesterday it was World Palliative Care Day. Did you know that, Donna? Today. So my cousin, who's a hospice nurse in South Africa, is doing a special presentation today. So I think there's a lot of things going on all around the world to celebrate World Palliative Care Day. So I just wanted us to recognize that that's what it is. I also wanted just to let you know that Jasmine is part of an organization called CARIPALCA, which is Caribbean Palliative Care Association. They just did a presentation with the World Health Organization. And as we heard from one of our speakers yesterday, the World Health Organization has determined quite a long time ago that palliative care is a human right, and that governments should mandate services and have palliative. Well, we're well behind that here, and we were in the region. I don't mean in Cayman. In Cayman, we're really quite, well, we're up there, we're advanced, and we see what goes on in CARIPALCA around the rest of the Caribbean region. And we are very fortunate in so many ways: access to opioids, being able to give care free at to service. So I always like to try and remember others who are not as fortunate as we are here, and share with them some of their challenges. So now we're going to move on to another panel discussion, and this is going to be about the pros and cons of palliative care. Donna Thompson is going to join. I'm just going to ask Dr. Shapir to come back. We've already heard what his bio is, if he's still here. And then I'm going to ask Dr. Natalie Sharp to come up. Natalie Sharp is our new palliative care medicine doctor. She's attended medical school at the University of the West Indies in Jamaica and went on to do a residency in hematology and medical oncology. She did a certification course with Harvard Medical School and a clinical stint at the University of Colorado in Denver. Her goals is the integration of quality palliative care into the management of advanced illnesses and providing access throughout all areas of the country. And so we're very pleased to hear from Dr. Sharp yesterday, and we're pleased to welcome her onto the panel today. Our next member of the panel will be Dr. Khan. Dr. Khan is a palliative care and hospital medicine physician at Massachusetts General Hospital and an instructor in medicine at Harvard Medical School in Boston. She completed her medical school and internal medicine training at Northwestern University, Feinberg School of Medicine in Chicago, and a palliative care fellowship through the Harvard Interprofessional Palliative Care Fellowship there too. She's a native of Senegal, and she's deeply passionate about expanding access to affordable and high quality palliative care in Senegal and Francophone Africa. So welcome to all of our panel speakers, and I will now let Leisha take that over.
Welcome. Thank you guys all for joining us. Left my notes. I want you guys to think of your questions too, but as I did before, we're going to switch it up a little bit as we met most of these between yesterday and today. These lovely panelists, we won't ask them how their services help with palliative care. What I'm going to jump into is my first question to you guys is, my doctor has not said anything yet about palliative care. Is it something I can ask for, and how would I go about doing that? And if each one of you could take a time and just answer that, that would be great.
Sure. Thank you. The fact that you're already thinking about palliative care is a great thing. So it is not uncommon that patients are actually the ones who request palliative care. We do get in Boston, for example, on the inpatient service, it's not uncommon that it's a patient's family member who's requesting palliative care, because now they're hearing more about palliative care in the media, in just layman literature. So what I would say is approach your doctor. If you have a family member or a friend who you're seeing declining and you think palliative care might be helpful, ask them to approach their doctor and ask about palliative care. And it may be that your doctor has all the information and can easily refer you. It may be that you have to actually educate them about palliative care, or it may be that you have to convince them that you need palliative care. Because again, a lot of us feel that we're already doing the work. Why do you need an extra layer of team to help out? But the fact that you're thinking about it means that palliative care would be a good idea. Just ask your doctor.
Hi. I mean, I think similarly here with Jasmine, we do get a lot of family and community referrals. And so, you know, people have heard about the services that we offer and what palliative care can do. And they do reach out to us and ask us, you know, can I just come see you guys? Can you guys help? I think it's easy enough to ask your doctor about if you have a specific issue. Think, doc, I think Jasmine can help me. They can come to my home. Most doctors, I think, at least here in the Cayman Islands, would be willing to work with us and partner with us. And also, if you come directly to us, we do reach out to your doctor afterwards if you want us to. We generally, Ginny definitely at least knows most of the doctors, definitely work in the community. And so we do have a good relationship with a lot of them. So, we can reach out to them on your behalf as well too.
I haven't done outpatient palliative care since fellowship time, but my answer would be in much the same way that one would want an expert in whatever realm of medicine that one or psychiatry that one is dealing with. And so one can seek out a psychiatrist, but if what one needs is an adolescent psychiatrist who specializes in grief, or if what one needs is a neurologist with a focus on individuals with dementia, then not all psychiatrists and not all neurologists are the same. And so too, a friend or family member will say, gosh, my loved one has cancer and is experiencing pain and nausea, and I hear there are experts, perhaps different than with a different focus than what the oncologists attend to, and with a different focus than what the internists attend to, but that there are experts and specialists who are very comfortable with complex symptom management in chronic illness and advanced illness. I would want those people. I would want to see those people, and so that would be my recommendation.
I think this is one of the advances that I alluded to earlier in terms of palliative care in our relationship with the rest of the medical world. And other physicians are much more accepting that, yeah, it would be really good to get some people from the palliative care involved. Things like pain and other symptom management that they may feel uncomfortable with. And so I think resistance has declined tremendously. And I also see a change in attitude of patients. I can remember back a long time ago, if you suggested palliative care to a patient, the most common reaction is, oh, so you're giving up on me. And I don't really see that particularly anymore. I think people are more aware, as it had been alluded to, that people are more aware of exactly what palliative care is. And so it's much more common to get requests from everywhere.
Perfect. Thank you guys so much for that. Do you guys have any questions? No, I'll go answer. I got it.
This question is specifically for Dr. Khan. Could you share with us how some of these practices translate to Senegal, to the African situation? And the thing is, I see a lot of this is from the Western cultural perspective. How does it translate to a different cultural perspective?
Thank you so much for that question. As somebody with a dual culture, meaning being from Senegal and eventually hoping to return back, but having done all of my medical training in the United States and practicing in the United States, this is a question that is very dear to me. One of my colleagues and friends from Rwanda recently published an opinion paper called Decolonizing Palliative Care. So it is true that the roots of the hospice, modern hospice movement and palliative care is from North America and the Western world. And a lot of the concepts that we use are very Western centric, even the concept of patient autonomy. It is not uncommon that when I'm on the wards that people are troubled by the fact that a family member is trying to shield their loved ones from their diagnosis. Where I come from, that's probably the first reflex that people have. So I think there's an important need in diversifying perspectives in palliative care, which brings me back to what I mentioned yesterday, that the best palliative care you can provide is the palliative care that is socially, culturally, and relevant to the context where you practice. So there are some cultural variations in Senegal in terms of how we talk about death and dying, in terms of the role of families as surrogate decision-making, our understanding of autonomy. I'm actually heading to a conference in December in palliative care in Senegal, organized by the Association of Senegalese Palliative Care Specialists, along with the Senegalese Society of Cancer and E-Cancer, where we're actually going to be kind of reflecting on what does palliative care mean for Senegal. And we're having a lot of those conversations starting on the African continent and in other areas about sort of keeping those core principles about taking care of the whole person, but really thinking about what does palliative care mean for us, not just sort of replicating exactly what was done in the Western world or in North America or Western Europe. And there was one other thing I wanted to mention that is escaping me now. I'll come back to it. There's something else that I was thinking about, but I think this is a wonderful question. There's probably the next steps. If I were talking about advances in palliative care, it would be that the same way we've talked about how do we integrate palliative care in disease-specific areas? How do we define palliative care in specific cultures, for example, and then also adapting it to specific resources. One last comment is that a lot of people in the palliative world, especially those who've sort of pioneered it, have conflicting ideas about that, right? Sort of the concern that we're going to denature what palliative care mean. When you say palliative care in a low resource setting might mean actually providing meals to family members, providing schooling fees for kids, that is one of the ways you palliate symptoms. People go, whoa, that's a little too far. Are we talking about economic development here or what, but I think there's a role for really thinking about if we're saying we're relieving suffering for the whole person, what does suffering for this person mean in their context, and how can we shore up the resources we have so we can be a little bit more inclusive about the definition. So let's stay tuned, but I think we can all play a role in that.
Can I add something? I think so. One of the things that I've learned, and from a person that Dr. Khan and I both know in common, who works with MGH and the Harvard Medical School, and he goes to different countries to help develop palliative care programs. He went to Belize and he, tried to develop, was developing palliative care there. And one of the lessons that he learned in Belize and when they were developing their system is that for certain countries and particular systems that we work in, it actually has to be more home-based care and palliative care in the home as outpatient, more so than hospital-based care. That was their experience that they had there, that people were really much more inclined, and the healthcare system was really much more inclined to buy in when you started with home-based care and palliative care at home.
Thanks. Just one last thing, but the relativism about what culture you apply this to should not overshadow the fact that it is a human right for people to have their pain and their suffering relieved regardless of where they live. It should not be an out for governments to say, this is not our culture, so we're not gonna provide access to opioids, or we're not gonna make sure that the healthcare system takes care of suffering for patients and their loved ones. I think that is the core of palliative care that should remain no matter what, and we should aggressively advocate for that, but then the contours can change based on where you practice.
Awesome. I will add to Dr. Khan, thinking of a patient we've had here in the Cayman Islands before, when you talk about suffering and what we try to impress upon people as we meet and we explain about the benefits of palliative care. Dealing with a patient that called me in a panic. They were in so much pain. The wife called and everything was pain. You got to the house and it's like, okay, where's the pain? And he's like, all over. And you're like, okay, we need to dive into this a bit more. What do you mean? At the end of the day, he couldn't pay his bills. He was waiting on needs assessment to get funding. They had no food in their fridge. They didn't know what they were going to eat. They were afraid their landlord was going to kick them out. That was his suffering. He was the male person providing the care for the loved one. And unfortunately wasn't able to do that because he was sick and he was bearing that burden and that's what we aim to, that's what we aim to help our patients with and make a difference, whether we're here or wherever we are. It's not just about the physical symptom, but about the whole family, the whole person and what they need. And so by getting the Meals on Wheels and by getting a call into the needs assessment, that's what we do as palliative care to support the patient where they're at to help alleviate suffering.
Yes, as a president of the Lions Club, I feel that that's where we come in. So somehow there needs to be some type of register where we and fellow service organizations like Rotary and so on are available to you for that opportunity to serve where NAU don't come in to play. And we do see that on Christmas morning when we do our Christmas deliveries. Every Christmas we go out there and we see the lock-ins and we see the people. And of course, Meals on Wheels often are like Monday to Friday and so on. Perhaps I'm wrong in that situation, but there would be a time where we as Monday to Friday employees or workers, are available most times at weekends for activities. That's when we can go out and support and maybe sort of put on a register of visitors to assist. So yeah, there's an opportunity there for us to step in.
Thank you very much. That's awesome. We hadn't actually thought about that. So we're loving the networking and the possibilities and the opportunities that is coming from this event. I'm going to pose a question because I don't see any hands in the room. You go for it.
I wanted to refer back to Dr. Rosenberg's talk on dementia this morning. Thank you very much for that, by the way. And ask in situations where someone is high functioning and very intelligent, do you find that they are more likely to compensate in different ways for that loss of cognition? And in those situations where you're caring for someone who kind of is adamant that there's nothing wrong and I can cope and I don't have memory loss, what are you even talking about? Are there any strategies that you can recommend that, can get us all on the same page so that there's less distress in making care decisions and in essentially, making sure that person stays well?
The answer is yes, that often the individuals who are starting from a higher baseline, whether owing to professional status, educational status, the like, can then become more frustrated with any perceived threats to taking away decision making and to their autonomy. My answer, maybe less as palliative doc and more as psychiatrist, is although this is something that primary care doc could do, whether they feel comfortable or not is a different question. It's something that a neurologist could do, whether or not they feel comfortable is a different question, and that is family therapy. That's a time to gather everyone, have, as I think I talked about in the lunchtime gathering, family meeting, maybe serial family meetings, so that the patient doesn't feel that conversations are going on behind their back. Family members are able to express their concerns, and often family members are able to express their concerns better in the presence of a physician or a provider. They feel that there's some third party that can mediate conversation. So it would certainly be an indication for families counseling, family counseling, for couples counseling. Sure. By the way, I'm tempted to respond if I can. Just one small thought about the sort of cultural element to palliative care, which was being addressed in the prior question. I worked at a 750 or so bed community hospital in Brooklyn, New York, which was home to a very large Asian population and a very large Orthodox Jewish population. And it admittedly helped being a Rosenberg in terms of knowing that in some patients who are Orthodox Jews, they themselves were not, even if they understood the situation, they were not themselves going to make a decision, and the family members were not going to make a decision. The decision would defer to the rabbi of the synagogue and the rabbi of the community. And I think it takes, so one, I was familiar with that process, but even not, I think it takes a certain flexibility on the part of the practitioners of palliative care to be open to these various situations and these various family dynamics and cultural dynamics and community dynamics, to avoid a rigidity of the patient has total autonomy if I deem them to have decision-making capacity, and I'm only going to listen to the patient. And medical, there's a place in medical training, I think, to teach that and to practice that. And again, if anything, I think palliative care is one of the most artistic dimensions of medicine, and art requires a certain flexibility and ability to adapt to whether the circumstances are palliative care on a global, a global scale or a cultural or religious dimension as well.
Far from Brooklyn, New York, is a very small town in New Hampshire called Nelson. Has about 100 residents. It is on a road off a tertiary road, and it's a very small village. It looks like something that was 200 years old, or maybe if you're familiar with the play Brigadoon, it's really out of it and very, very different. And I think the point I want to make is that besides macro cultural differences, there are many micro cultural differences, because in the state of New Hampshire, they have a major medical center at Dartmouth and some big cities. But here's Nelson, which nobody can even find. And my husband's aunt spent most of her life there. And this summer she died at age 99 and a half and had lived an incredibly independent life. She still was very intelligent. I didn't see any signs of dementia. And, but they were far from anything, and there were not a lot of services around. But her community took care of her. She had very bad eyesight. She was no longer able to drive. She had some ambulatory issues, and people were kind to her. And there was somebody who brought her food occasionally. She didn't like that. She made dishes for other people as well. She was very upset that because of her vision, she couldn't deliver Meals on Wheels anymore. And she died a very peaceful death. And at the memorial service for her, everybody in the town came, I think, plus all her relatives. She's a wonderful person. And her son gave a speech. And I thought it was a wonderful comment. And this, I'm bringing this up because it goes along with all the different examples of palliative care. Jack said, Nelson was my mother's assisted living and palliative care. And it was the community. There was no formal organization. It was the community. And I have a feeling in modern society, we've lost that a little bit. We've become more fragmented. I think COVID didn't help when everybody was in their house. And I'm not saying that professional organizations aren't good, but I don't see a lot of community anymore.
Yes, good morning, everyone. I think it's natural for everyone to be afraid of death. But in the palliative care sector, do you find many people expressing concern about or fear about death, dying at the stage when they realize that death is inevitable? And as a secondary question, how do you go about caring for people if they do express those fears?
That is, so going to use the word existential crisis or existential distress. Again, this is just one framework. There are many, many ways of thinking about it. That is probably what I would call the palliative care emergency. We are lucky at Massachusetts General Hospital that we actually have a palliative care chaplain who is taking care of just palliative care patients. We also have access to other chaplains in the group. So I don't want to equate spirituality with religion, but this gets at the core of what some patients, not a lot of patients, but some patients definitely have this just existential crisis about, I want to live longer, but things are ending. I can think of, for example, just last month, a couple of patients I took care of. One was a 45-year-old woman who was dying of breast cancer. Another one, a 39-year-old gentleman who was dying of rectal cancer. Both had families with young kids. Both had had their disease actually that they were living with for over 10 years and kind of had beat the odds and were coming with really this was the end. And there was this bargaining, and you walked in the room, the suffering was palpable. They could not tolerate a conversation about, do we go to the ICU or not? It was just unbearable. So the moment you started talking, a distraction would come up in the room, and the suffering was just palpable. And in those cases, I think that's where you muster up all you can. You first need to realize that you can't fix some things. I think all of us to some extent have this fear of dying in our genes. It's like the terror management theory. It's not in our genes to die. So we're doing everything to kind of prevent it, even though spirituality sort of allows us a little bit to be able to sit in that space, to first recognize that as palliative care providers, most of what we do is actually sit in silence with suffering, that not going with the idea that I'm going to make you accept that you're going to dying. Those two people actually died never accepting that they were going to. And they died not telling us that they were going to die. I had to actually tell the team, they don't have to tell you that they know they're dying. You know they know they're dying. You can see it in their terror. Can we actually make this process bearable without having to really talk about this thing? So we talked about it with their loved ones. We talked about the fact that regardless of where we were heading, we were going to make sure that they were comfortable. We tried to figure out what their biggest concerns were. For the woman I mentioned, it was her kids. It was making sure that her son, who was 19-year-old, was going to be okay. For the 35-year-old, it was something else. But figuring out one thing that was concrete that we could kind of sort of help them sort of make better, but mostly just realizing sort of the enormity of this thing called life and death, even though we naturalize it, just understanding that it's still difficult. And we were obviously lucky. We had the chaplain, we had our social workers, we have a team called the Parenting at a Challenging Time, which is made of psychiatrists and psychologists that were able to actually talk to them and their parents, meaning the grandparents in this case, about how are they going to help the kids deal with the grief. So all of those things we kind of got together, but understanding that we're not going to go into it with things being just perfect and fine. Not everybody is perfect and fine with dying, but can we actually sit in that suffering and acknowledge and see them? And I think there are many different ways to do it, but that's what we did with the resources we had.
Yeah, I think a lot of people have difficulty with the fact, with their own mortality. And with these patients who are having these progressive illnesses, one of the things that in my experience, that I've realized is that usually, a lot of people can say, okay, well, I have this illness and, I know it's terminal and it's gonna take my life at some point in time. But as you are actually approaching there and it's getting closer, it becomes a lot harder to deal with. But what I've seen is that when it comes to like the last 72, 48 hours, patients generally tend to know deep within themselves, they know that it has started and, things are going to happen. And at that point in time, things can go several ways. There's some who say, well, I can feel it coming, but I'm glad that it's ending. The suffering is ending, whatever's coming next, at least I'm ending what I've been going through. There's that mentality. There are people who have that. There are people who, as Dr. Khan alluded, you just need to figure out what is causing them distress. Is it the loss of what they're leaving behind? Is it worry about, how is my wife going to manage, after I'm gone? Is she going to be okay with this? Are the children going to be okay? So at least part of that time is figuring out what is causing them distress. And then, there's a third group that, have been thinking about it all along and, do know that, they come to terms with it eventually. So it really is kind of just figuring out in those but people generally tend to know. And it's kind of just figuring out in those last few, days or hours, what is bothering them, helping them through that. And also I would like to make a plug for somebody like Rhonda, grief counselor, who, if you can involve her earlier than those last few days and hours, somebody like that will kind of help you come to terms with things, as you go along during the process.
Oh, I love your question. It's a very deep question. I'm interested in why you ask it. What comes to mind for me is I feel I've seen the gamut, and two cases from fellowship year come to mind. One was a probably 60-something-year-old man with an advanced melanoma who had come into the hospital with severe shortness of breath, and he was there with his wife. And it just admitted to the general medical unit, and palliative was consulted. And by the time I got there, I walked in the room and I said, "Hi, I'm Dr. Rosenberg with palliative care." And he said, "What's taken you so long? I'm ready to go." I'm familiar. I've had this disease for X amount of time. I'm prepared for my death. My wife is prepared. My children are prepared. Take the pain away, make me comfortable. I know it's the end. And he was ready. And I said, "I'm here and I'll do all those things." And on the other end, it often is the case, I think, in younger people, those dying their 20s, 30s, 40s, especially if they have spouses, especially if they're young children, sort of lives cut short. And I might say even more than sitting in the suffering, which I feel very comfortable doing, and I'll have a comment about that. I actually like to and want to move around in the suffering. And I feel that, meaning not me but with that person, I want to move around in their suffering and explore their suffering with them, their emotional suffering, their psychic suffering. I've come to see, and it was a mentor of mine in hospice care who works in Israel, taught me and showed me, and I've seen it myself, that often when accompanied, and whether that accompaniment is measured in sort of psychic millimeters or psychic miles, a person can move through, can make some progress, can achieve some level of comfort. some amelioration of their, again, their existential distress, their psychic distress, when accompanied, when allowed to be with deep emotion, when they have a person, it need not be a professional, but it often helps when a professional to be with them in their tragedy and in their suffering and in their pain. And I don't just mean physical pain by any measure here. I'm talking pure emotional pain, that they can move through it. They can express it when given a voice to express and given a space to. And sometimes even the secret sauce is simply being allowed to express that, to convey the horrificness of a life cut short, of not being able to be with their children, of not being able to be with their spouse, of simply all of that. I shed tears with patients. I shed tears with family members. I'm deep in the emotion with them, and I think that people can make some movement through it, and that I think is an aim and an achievable goal of a palliative doc, of any doc, of a palliative of any provider, is to help move them from where they are to somewhere else, and that movement actually comes naturally, given a good listener, a capacity to an ability to express what they're feeling. And that for me, I mean, your question again, I like, and it touches on what is one of the most moving dimensions and important dimensions of palliative care. I feel many docs could be trained to titrate medication for pain and for nausea and for seizures and for all kinds of things. But again, the artistry, I think, of this domain of medicine is how do we be in those critical moments with that deep tragedy and actually bring about an alleviation of suffering in that space.
Yeah, it's just that sometimes a part of it is just being with the person and, you know, just saying with them, yes, I know this is not fair. This has not been fair to you. You know, you had plans, there were things that you wanted to do, and it's just not fair. And sometimes that's all they want you to be with them and hear them say.
I agree with that very much. And I think Shapir's comment of moving through the death experience, I guess I would call it. And I think the thing that has given me probably the most pleasure and amazement in working with these people is no matter kind of what their background was, where they came from, their level of education, their religious feelings, you know, all kinds of people, how amazing people actually are in handling death. And my experience has been that I've not seen a lot of rage against the dying of the life, that almost everybody I can think of ultimately reached a place of peace, whether they were 20 years old or 90 years old. And I can't tell you how many times at the end of the day, I think, wow, how did this happen? And I'll just mention one case who I had as a patient who I didn't think would ever move through it. And this was a colleague of mine, a man who was about 52 years old. He was an orthopedic surgeon and a big, strong, very macho guy, played football, and he was really tough. And when I had my first conversation with him, he had adenocarcinoma of the GE junction. And it was very, very tough. He had a complicated surgery to try to get rid of it, and some radiation, some chemo. And within a very short time, it came back. And he had a lot of suffering in a lot of ways. He couldn't eat. He could barely swallow. He had a lot of pain as the disease progressed. When he first heard the diagnosis, I actually was talking to him in his office. And he said, well, I don't know how far I'm going to go with this. I mean, I know about this. And if it gets a little tough, that's what I'm going to do. And I thought, well, you know, knowing Andy's personality, I could maybe see him being a guy who did that. So over the course of about a year, this man went down to about 98 pounds. He had a feeding tube. He still wanted to be alive. I didn't think he'd ever accept a gastric feeding tube. And then near the end, he was also on a morphine drip. And he actually got very philosophical, and he said to me, I know I have a very diminished life. And if I went back to where I was a year ago and I said, if I had this quality of life, I would kill myself. He said, but I have a family, I have children, I have this very diminished quality of life right now, but it's all I have. And I want to enjoy the teeny tiny spark of life I have left. And very shortly afterwards, he died unbelievably peaceably.
I realized I forgot to tell you, I'll tell you one small, I forgot to tell you the other side of the gamut from the gentleman who was very ready to 30-something-year-old woman with a spouse and little children at home who was dying at Moffitt Cancer Center in Tampa, where I was doing fellowship. And she was Spanish speaking, and I don't speak Spanish. And she was dying of a peritoneal carcinomatosis. I forget the original kind of cancer. And walked into the room, and the room was simply heavy. And the children were there at first, and we decided maybe we'd have the children step out for a little bit, and it's just spoke through the interpreter with the woman and with her husband, and a nurse was there. And what I'll say, and the reason I wanted to share this dimension of the story was at some point, maybe an hour into the conversation, there were tears in my eyes, there were tears in the interpreter's eyes, there were tears in the nurse's eyes, talking about that she was facing end of life. There were no more chemotherapeutic options for her, and home hospice would be most suitable for her. All the talk, ironically, of communication in palliative care, I think there are things that transcend even language. And I didn't speak her language, and she couldn't benefit from what I think is a strength of mine, which is how I use my words. I think there's even a place in these hardest of situations for some kind of core human understanding as conveyed in our presence and in our eyes and in our tears, and a willingness on the part of providers to be deeply in, and often deeply in means with our own tears in these settings, to be with people who are dying, not simply patients, but actually just people who are dying, and to bring our own humanity there. So I thought to make mention of that, as sometimes there's even beyond simply language, and and yet I nevertheless felt, and she felt, and the others, that we were able to communicate, and she was able to make some emotional moving through, even though we didn't have I didn't have the direct language connection with her.
Thank you. In the interest of time, even though I could keep talking and asking lots more questions, I will leave it with you guys if you want to each give some final words, thoughts, wisdom to us, the audience, before we close.
Okay. All right. Well, thank you so much for inviting us, and thanks for the warm welcome and the attendance. I hope that the last couple of days have been at least a little bit instructional in one way or another for each one of you. I have just 2 micro points, but that I think are quite important, and I'm going to tie your question with 2 things we talked about today. One is grief, and the other one was about advanced directives. So, and this kind of goes with what we do in palliative care. It's about curiosity. But I wanted to mention that grief is not just about losing something you had access to. It's about losing a future. A lot of the grief is about the future that we were promised. For example, my 45-year-old woman who thought she was going to be here to see her son get married and her grandkids, and she kept saying, I'm not going to see my grandkids. So a lot of grief is about anticipating a future lost. And I think early integration of palliative care allows early grieving in very artistic ways. You can sort of address and do some of that work, which is what Dr. Thompson did with her patient, who then a year later actually was able to handle things better than he ever thought he would. And that brings me to the second point, which is that we all have sequential selves. Who I am today is not who I was 5 years ago. It's not who I'm going to be 5 years from now. And it's the same for all of us. So some of the tools we use in medicine and in palliative care can be rigid sometimes, but That's because we have to have a way to operationalize things. So advanced directives is one of those. We have to have a way to sort of make it less messy, that people are dying and facing difficult challenges without no one ever knowing what they wanted. But we understand that what people want now may be very different from what they want. There are studies that show that a lot of clinicians say, if I have stage 4 cancer and this and this and this, I don't ever want to get chemo. But once they are in that situation, they actually say, yes, give me more. So understanding that human beings are sophisticated, and that the person you have in front of you is the person you're talking to, being curious about what they want. But some of these macro things we do are very important because it's just the way we operationalize it. But we can always sort of look at the individual in front of us. So our sequential selves, and grief is more than just what we lost. It's about really anticipating what we're not going to have that we thought we were going to. Thank you.
Hi, again, thank you everyone for coming yesterday and today. Really appreciate it. And I'm really happy to see the interest and the turnout. So thank you guys for coming. I think the one point I would like to make is that what I want everybody to understand, palliative care is person-centered. It's person-centered care. And I use person-centered as opposed to patient-centered because the people we treat are not just, we don't want to like to look at them as just a patient. It's not just about their disease. It's about every aspect of their lives. And that's how we determine what the best care is for them. So it's about their family. It's about their past. It's about who they were. It's about what they want for the future. So palliative care and what we do is person-centered. And I think all our presentations yesterday and today have kind of highlighted that, in how people make decisions, the care we choose for them, and how we, feel, how we operate going forward with them and their families. So person-centered care.
I don't know that I have any grand thoughts or grand summative thoughts. First of all, I personally appreciative to Dr. Thompson for nominating me to be here, and Felicia and the Jasmine organization for inviting me to be here. It's been lovely to come to know the Cayman Islands a little bit, and some colleagues from local and further away. I suppose one thought that comes to mind is in palliative care and in all of medical care, to not be afraid to, as you said, we're sophisticated human beings, and I would use the words rich and complex as well, and to not be hesitant to use your own richness and complexity as a person to connect with others who are going through illness and suffering and dying, and frankly, for the patients, it's deeply meaningful to have doctors and providers who truly care about them and are willing to bring their own humanity to bear. And for us as providers, it's for me at least the most meaningful stuff of life, to have these profound encounters. Frankly, the more tragic and intense, often the most meaningful. And so simply to embrace the richness of our own lives, and to not be afraid to bring that to the lives of the people we encounter.
I think what everyone has said is so true about the rewards of palliative care, which many people from the outside could not even guess at. And it's wonderful. I have to say, it is so great for me to be back here. I've been to several of these conferences now, and it's always nice to come back and see old friends. And yet I always learn new things every time. The interaction of everybody is really great. And to meet new colleagues who I know for sure I'm going to see you around, and it's just great. And I really thank Jenny and Felicia for keeping these conferences going, and even managed to do the Zoom during COVID, and sort of keeping the faith, so to speak. And once again, I really want to congratulate Jasmine. They have been a fabulous institution since they started.
Can't thank you enough for those kind words. We are humbly grateful as well to you guys for taking the time, for making the trip, for making the effort to help educate our population, like I said yesterday, about increasing the care here in the Cayman Islands, the access to care. There are misconceptions, but one by one, I think we're managing to break them down. If I could quote anything from the minister's message today was, I implore each one of you here to go and tell not one, but two people what you've learned. Share the knowledge with others so that many more people will be reached by what we're trying to do. I am passionate about ensuring that everyone that's on our shores have access to supportive care early in their diagnosis so that we not only can Jasmine help them, but they can have the best quality of life. That's the goal of this mission. It's uncertain times. We don't know what's going to happen. With COVID showed us anything, we just don't know what it's going to be, but no matter what, we want to ensure that patients get the care they deserve. As they said, it's a human right to have palliative care. And if we could manage to get the Cayman Islands to recognize that one person at a time so that no one suffers and no one's alone, then we would be able to do that much more and set the stage for the world for what it can be when you actually really put this care into people's hands. So thank you all for coming. We have some gifts for you. We're very, very grateful. We're thankful that you guys all stayed. I do have to do my little homework, which is thank our sponsors. Yet again, I will say, as a nonprofit, we don't have funds to put on a huge conference, but by the grace of God and the support of Healthy Futures, the Health Service Authority, Health City Cayman Islands, the Wellness Center, Baptist Health, Willow, and Aon, we were able to offer this to you guys as well, free of charge, and an anonymous donor. That speaks leaps and bounds of what we have the potential to do that some other countries, many other countries don't have the options to do it. So let's not waste it. Let's pay it forward. Let's make a difference. And thank you guys for coming. Oh, wait, one more thing. Sorry, I have to say this. When I said I was going to put on this conference and when I said it was going to be 2 days, I had many people tell me I was crazy and that what was I thinking? So I have to stop and say, this is not a Felicia thing. This is everyone. If I stamp at first, I want to thank Ansley, Jada, Crystal, she's out there, Dr. Hobday, all of my nurses, everyone pitches in, everyone does what they can do. We fold, we print, we run errands, we do what it takes to make it happen, to keep the cost as low as we can. We're grateful to April. I can't think of the company's name that did our live video. This was literally put together in less than a week. It's like, we want it to be live. How do we make it happen? And everyone just pitches in. So I'm very grateful. I could not do it without an amazing team of workers. So thank you all to my coworkers as well. Oh. Surveys on your desk. If you fill them out and hand them in evaluation forms, you can get a CME if you want one. And if you just want a certificate, you're welcome to have it as well. And thank you all for coming.
Said stop recording. I hit stop recording. I hadn't hit stop for virtual camera yet, but it said start streaming. It looked like we weren't streaming. Okay. Okay, I stopped virtual camera. It won't let me stop. So OBS is currently active. All streams recordings will be shut down. Are you sure you want to exit? Stop virtual cam. Yeah, I said I stop recording. Yeah. I stopped virtual cam. Okay. Are you coming by here? Or? That's what you want to do. Yeah, that's a good idea. Did it go okay, you think? Almost exactly perfect. Almost exactly perfect. Okay. That is.